All right, good evening, ladies and gentlemen. This is the third night of our gynecology. Let me just shut off my speakers here. And we're going to start on chapter 4. I'm sorry, this is the second night of gynecology, not the third. Lo sientos. All right, we're going to start with disorders of the cervix and uterus. First, we'll start with cervical lesions. In your book on page 167, it identifies cervical somewhat. There is a illustration in your book which isn't super hot. But what it is, it shows the prolapse of the columnar epithelium of the endocervical canal. It is very vascular because remember, the blood vessels are only one cell from the surface on columnar epithelium, but they are benign. And I showed you previously how you can take this out using a ring forceps, grasp it, and then twist it, and should be no problem. Okay, Nabothian cyst. Let's talk briefly about Nabothian cyst. Nabothian cyst is a mucus-filled cyst on the surface of the cervix that is lined by glandular cells that normally secrete mucus, and those mucus-producing cells are covered by squamous epithelium. It is an incomplete metaplasia. Normal metaplasia completely removes the underlying columnar epithelium and replaces it entirely with stratified squamous. In this case, there's stratified squamous on the top, but there is still mucus-producing columnar epithelium underneath. And what will happen is the mucus which is being produced cannot get out because it is covered by the stratified squamous epithelium, and so it bulges out. And here you can see with the yellow arrow, the bulging out of the Nabothian cyst. Now you can see that the reddish area, which is the endocervical canal, is lined by columnar epithelium. That's the columnar epithelium. There you can see the squamocolumnar junction, which is where the red and the pink come up. This is the new squamocolumnar junction. The Nabothian cyst will always be in the transformation zone because the transformation zone is where metaplasia occurs. So it's always going to be between the old and the new squamocolumnar junction. Here you can see a fairly large Nabothian cyst. And again, you can see the new squamocolumnar junction is here. Obviously, the old squamocolumnar junction was out here because that's where the old columnar epithelium used to be. And that's what's producing this cervical mucus. Now, let me show you some histology. Here you can see this is the endocervical glands. This is the columnar epithelium on this side. This is the endocervical canal. Then we have the ectocervix out here. Now, this is stratified squamous epithelium. This is where the old squamocolumnar junction used to be. This is where the new squamocolumnar junction is. And this area between where the Nabothian cysts are is the transformation zone. And you can see that the area is covered by stratified squamous epithelium on the top, but these mucus-producing areas are still at work, making the mucus which can't get out. They're benign. You don't need to worry about them. That's just a interesting phenomenon. You don't need to do anything about it. Cervicitis. The Center for Disease Control, the CDC in Atlanta, Georgia, is so concerned about sexually transmitted diseases and PID that they have defined cervicitis as a clinical diagnosis, not a laboratory diagnosis. It used to be a laboratory diagnosis. You would take a culture and the culture would come back and tell you what organism was involved. They will make a diagnosis based on either the presence of mucopurulent cervical discharge, or what they call mucopus, or a full cultures for chlamydia, for gonorrhea, for trichomoniasis, or whatever you're looking for. But you don't wait to make the diagnosis for the culture. This is mucopurulent discharge or mucopus. When you see this, coming out the cervix, this looks like waterfall, which is frozen. It's not pure clear water. This is pure pus. And that is indicative of cervicitis. This is a friable cervix. Friable cervix is a cervix which, when you touch the columnar epithelium with a Q-tip, it bleeds. Or it can even bleed spontaneously. Normally, you can touch the columnar epithelium and it doesn't bleed. But when you have this sort of a finding, this is endocervical canal, that is a second criteria by the CDC for cervicitis. So either you have the mucopurulent cervical discharge or a friable cervix. And we'll talk more about that when we get to PID. All right, now the big issue, which is cervical neoplasia and pap smears. Here is our case, page 169. A 25-year-old woman is referred because of a pap smear showing HSIL. Now, what does HSIL mean? The H stands for high grade squamous intraepithelial lesion. HSIL, high grade squamous intraepithelial lesion. We'll come back to that a little bit later. This is a serious advanced form of neoplasia, at least on a pap smear. Her last pap smear 2 years ago was negative. She's been on combination steroid vaginal ring contraception for the past 4 years. There should be no impact of either the IUD or the vaginal ring on abnormal pap smear. Her cervix is unremarkable on gross visual inspection. So on pap smear, she has HSIL, but when you look at the cervix, it looks normal. Does that make sense? Would you expect a patient who had an abnormal pap smear to have a abnormality? How does it present? What are symptoms? And the fact is, usually none. Cervical is a silent disease. No symptoms at all. Where do you typically find cervical dysplasia? We talked about this yesterday. The transformation zone. That's why when you do the pap smear, you need to be sure that you scrape the transformation zone, because that's where the most likely findings will come from. The cause, it is mediated through HPV. A woman who has not been exposed to HPV will not have cervical dysplasia. Now, most of the time, that is transmitted sexually with penis and vagina intercourse, but you could have with manual stimulation. It could be as well. In other words, a woman can say, well, I've never had intercourse with penis and vagina, but you could still have exposure to HPV. This is an important one. Most cervical dysplasia will regress over the next few years. Far more women develop HPV than retain it. Most of the time, it is a temporary, a transitory phenomenon, and it goes away on its own. If the HPV is going to lead to cancer, it is going to be a slow process, going from to SIN2 to SIN3 to carcinoma in situ, and then invasive cancer. So there's lots of time typically to identify this with pap smears. All right, this is in your book on page 169. And what I was just saying is that the majority of HPV will spontaneously regress. 20% will stay the same, and only 15% will progress. Only 15% will progress. So what is it that determines whether it will regress or whether it will remain? And it is the HPV DNA type. The benign, which will usually regress, is the HPV DNA type 6 and 11. The types which are concerning that can go on and progress would be HPV DNA type 16, 18, 31, 33, 35, and so on. Okay? So there is a point at which the HPV DNA can be helpful in sorting out an abnormal finding. Does it lean to a regression modality or does it lean to a worsening? Again, the natural history of cervical dysplasia is a response to HPV DNA types. 65% will regress, 20% will stay the same, and this depends on the HPV DNA type. This is exactly on page 169. Now, what is interesting is these are benign. They are the 6 and 11. Women weren't immunosuppressed on steroids or something like that, because you generally don't see this severe a case. I mean, you don't even see the anus, you don't see the vagina, you don't see the structures. Okay, this has a couple of take-home messages. What we're looking at here is a percentage of lesions which are HPV. This shows that HPV DNA type 16 is more associated with squamous cell carcinoma, and the HPV DNA type 18 is associated with adenocarcinoma. That would be worth sticking someplace in your brain. The 16 and 18 are the most common ones. You can see there's 45, 31. There's dozens of HPV types, but it's the 16 that most likely causes squamous cell, and the 18 the adenocarcinoma. That's why we need to get a sampling of both the squamous cells and the columnar cells. This is showing cervical cancer as a percent of HPV DNA type. And the purple one here, which is the most common, is HPV 18. I'm sorry, 16. And the green is HPV DNA type 18. And the 16 is a squamous cell. Okay, young women who engage in sexual intercourse will very likely develop HPV infections. When you look at the data, half of men have HPV infections, and the transmission to their sexual partners is almost predictable. What will happen to most of these HPV DNA infections? And this is a study where they identified low-grade squamous intraepithelial lesions on women who were young, and they didn't do anything. They just followed them to see what would be the likelihood of them spontaneously regressing. And what they found was, after 1 year, 2/3 spontaneously disappeared. And after 3 years, 90% spontaneously disappeared, which means the majority of HPV, the majority of cervical dysplasia is going to take away, it's going to go away without you doing anything. That's why the recommendations for the onset of pap smears, it is age 21. Because if you've got HPV and you find it in these young women, and if it's going to go away on its own, why bother even finding it? Let it go away. All right, screening. This is a stamp, a USA stamp. Look at this, 13 cents. You know, this is, and it's Dr. George, who was the pathologist at Cornell University, who in 1928 described the role of vaginal cytology for the prediction of cervical cancer. Now we are honoring Dr. Prepubertal. The cervical pap smear is the most effective cancer screening test in medical history. It is the only screening test with a 70 to 80% reduction of a death rate due to prevalent cancer. The most common cancer in women today is breast cancer. The most common cancer used to be cervical cancer. But because of pap smears, look at what's happened to the rate of cervical cancer. A significant and remarkable reduction. Okay, let's look at your handout. And this has information that you need to know for the exam. When do you begin pap smears? Oh, let's go. We begin pap smears at age 21 on all patients, regardless of onset of sexual activity. If a 20-year-old comes in and says, I'd like to have a pap smear, your appropriate response is, come back in a year. If an 18-year-old comes in, you say, come back in 3 years. You might say, well, what's the problem in doing a pap smear? I mean, it's uninvasive, non-invasive. Well, the problem is you may end up doing all kinds of diagnostic procedures like cone biopsies on lesions which will go away on their own. So do not do a pap smear under age 21. All patients, regardless of onset of sexual activity, start at age 21. Now, every 3 years would be recommended for women between the ages of 21 and 29. And the recommendation is to do the cytology only. Don't do the HPV DNA testing, because if there is an abnormality, it's most likely going away on its own. So don't even look for it. Just do the cytology, and you can repeat every 3 years. Now, we used to do these every year. Now we're saying every 3 years. If the woman is 30 years old or greater, and you do a cytology only, and it is negative, you did not do HPV DNA typing, that's okay, and you repeat it in 3 years. Now, if she is 30 years of age or older, and you do both a cytology, which is negative, and HPV DNA typing is negative for high-grade types, then you can go to every 5 years. And this is a recommended. The recommendation is 3 years, no HPV DNA on ages 21 to 29, and ages 30 to 65 is to do both the cytology and the HPV, and if both of those are negative, you can go to every 5 years. When can you stop doing pap smears? At age 65, if she's had no abnormal pap test in the past 10 years, you're done. You can stop at any age if there is a hysterectomy, a total hysterectomy. It could be a total abdominal hysterectomy, it could be a total vaginal hysterectomy, but if it is done for benign reasons, if it is done because of endometriosis, if it is done because of Leiomyomas, if it is done because of adenomyosis, we'll talk about these later. So if it is done because of cervical dysplasia, because of carcinoma in situ, of recurrence, that's different. If you've had SIN 2 or SIN 3 or cancer, then you continue on for 20 more years. Okay? So, very different. Pap smear classification. This is the Bethesda system, and this is the terminology that we use. The most likely outcome and what you would like it to be is negative. The pap smear is negative for cancer and intraepithelial lesions. Great. These are normal appearing superficial squamous cells from the cervix. Then we have atypical squamous cells, and there can be two kinds of atypical squamous cells. There can be atypical squamous cells of uncertain significance. There can be atypical squamous cells, cannot rule out high-grade lesion. Then there is low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, and cancer. So negative, ask A, ask I think what I might like to do if I rearrange this would be to go negative, ask H, and then LSIL would be right following this. Then ask H, which would be followed by HSIL. And I'll talk about this more later. It is in the book. Ask us here, ask us, is a concern that it could be LSIL, but there's not quite enough to make that distinction. Ask H is concerned that it could be HSIL, but it's not quite doesn't have quite the criteria. So it probably should be negative, ask us, LSIL, ask H, HSIL, and cancer. AGC NOS, AGC neoplastic. And what this means that the cervical endocervical cells assessed in AGC NOS and AGC neoplastic. Okay, when the cytology comes in, it is not looking at histology. It's looking at individual cells, which are this only looks at surface cells. Are you with me? On this. And these basal cells start to proliferate and they make their way through the epithelium from the bottom to the top. If on the biopsy, the lower third, so epithelium dysplasia 1, if it is 50% involved, as you see here, we call this SIN 2. And if it is almost all or all the way through, we call it SIN 3. Again, 1/3, SIN 1, 50%, SIN 2, full thickness, SIN 3. Now, this is in your book, and on page 1 is either low-grade SIL, high-grade SIL. The histology is SIN 1, SIN 2, or SIN 3. And when we do a biopsy, we need to compare is the cytology and the histology agree on the histology. What if your pap smear showed HSIL, but on your biopsy, you found only SIN 1? It doesn't fit. Do you see that? It doesn't fit. You didn't find on your biopsy where those abnormal high-grade cells came from. And that is when you do a wide and shallow cone biopsy. Okay, let's just review this again. This is on page 171 of your book. If we have LSIL, we would expect on our biopsy to have SIN 1. If we have HSIL on the pap smear, we would expect on the biopsy to have SIN 2 or 3. If we have cancer on the pap smear, we would expect to see on the biopsy invasive cancer. And they should be consistent in the severity. Now, when you look here, here is the surface. This is epithelium. This, and I put in red dotted line here, the basement membrane. The basement membrane is intact. On the histology, it is important to know, is it intraepithelial or is the basement membrane broken? If it's intraepithelial, then we cannot have any metastasis because you have no lymphatics or blood vessels in the epithelium. Now, what do you see here? Here is our epithelium. Here is the basement membrane right here. You kind of lose it here. But what you see here is there is a tongue of the abnormal epithelium which is penetrated through the basement membrane and is now invading. And whether we call it microinvasive or minimally invasive depends on how many millimeters deep it has gone. Now, we don't have a ruler to assess how many millimeters it will have gone down, but on the histology report, it should tell you that because that's going to be important in the staging. So compare basement membrane is intact to there has been breaking through the basement membrane, and now we could have either vascular or lymphatic involvement. Here you can see big chunks of invasive squamous cell carcinoma. They've come through and they are way down deep in the stroma. Do you see that here? Compare the difference between this and this. So that's where the histology comes in, where you actually take a biopsy. Okay, diagnostic approach. The diagnostic approach to abnormal pap smears could be either a repeat pap, an accelerated pap. Instead of doing it every 3 years or every 5 years, you do it every 3 months or 6 months or a year. Then we have HPV DNA testing. If we have a certain kind of abnormality, which we'll go over, then we can do HPV DNA testing. Now, both of these, accelerated pap and HPV DNA testing, are non-invasive. And so we will typically do this for the lower, the less severe pap smears. And that would be ask us and LSIL. I'm going to come back to that, so you don't need to write it down. Colposcopy and biopsies. We talked about that. I showed you pictures of how you do the colposcopy. Endocervical curettage, narrow and deep cone biopsy. These are all invasive. And so we will reserve this for the more severe lesions. And we always need to compare the severity of the pap smear and the biopsy, because if the pap smear is worse than the biopsy, then we need to do a wide and shallow cone biopsy. Okay, accelerated repeat pap. That's pretty straightforward. You just go ahead and do the pap smear as you did previously. Now, there's two different kinds of pap smears. We talked about that yesterday. You can do the smearing on the slide, such as this, or you could do the liquid-based, where you shake the cells into fluid. And these are both equivalent, and either one would be okay. Now, there are advantages to the liquid one, because you can do the HPV DNA typing as a reflex. Okay, the HPV DNA typing, we already talked about this. I showed you this picture. It's important to know, is it HPV DNA type 6? Is it HPV DNA type 11? Is it 16? Is it 18? Is it 30, 31, or whatever? Now, typically when you do the HPV DNA typing, what they will do, the lab, they will send you a report, and it will say high-grade DNA found, or negative for the high grade. In other words, the kinds of HPV DNA which could tend to progress onto cancer. So it will be basically a negative or a positive. You know, the HPV screening is really, really sensitive. And notice here, women who are negative on both the cytology, the pap smear, and the HPV test have a 2 per 1,000 risk of cervical cancer. That's why once you have a patient between age 30 and 65, if you do an HPV and a cytology and they're both negative, you can go every 5 years. Here you can see the sensitivity for detecting HSIL on the conventional pap smear, on the thin prep or the liquid, and the HPV DNA typing. I wouldn't be surprised if in the next 5 to 10 years, we stop doing the conventional pap smear, the cytology, and we only go to HPV DNA. Because if the HPV DNA is negative, you don't have any risk, because it is always mediated through the HPV DNA. All right, the colposcopy and biopsies, we already looked at this. This is reserved for the more severe abnormalities on the pap smear. And we use this binocular instrument to look at the cervix. Now, this shows very nicely the new squamous-columnar junction, right? You see it there. Here we have the Nabothian cyst. So you know that probably the old squamous-columnar junction was out here, and the area in between is the T-zone. That's where the cervical dysplasia is most likely going to develop. So when you do your sampling, when you do your scraping, or when you use your brush, this is the area that you need to make sure that you include. Okay, this is on page 173, and we already went over this yesterday. The brown is your old, what they call native squamous epithelium. This is the outer circle, is the old squamous-columnar junction. This is the new squamous-columnar junction. The area between is the transformation zone. The point of this image is to show that here we have, this pink here is the columnar epithelium, is that we don't have any of the T-zone epithelium going in to the canal. The T-zone epithelium does not enter the endocervical canal. Therefore, this is called satisfactory or adequate colposcopy. That's important. Notice the difference. Can you see here, this transitional zone epithelium is entering the endocervical canal. Now, you don't know how far it goes down. You don't know if further down in there is some dysplasia. This does not look dysplastic. And so what will be the management if you have an unsatisfactory colposcopy because the T-zone metaplastic epithelium goes into the canal? Our next step in management will be an endocervical curettage. Endocervical curettage. All right, the metaplasia, which is the transformation of the columnar epithelium to stratified squamous, is not dysplasia. It is a normal physiologic event which happens in all young women as they go through puberty. The pH of the vagina goes down, and we have this transformation which occurs. It is not abnormal. So, normal or satisfactory colposcopy, unsatisfactory colposcopy, this needs an endocervical curettage. Okay, this is on page 172 and is really a high yield summary. So we'll spend some time looking at this. What I would like you to do is to write in here age 21 to 24. We treat young women, ages 21 to 24, different than women who are 25 to 64. And this is going to be an example of that. Notice I have drawn a horizontal line between the upper two and the lower two rectangles. We can call this top one less serious. Ask us, LSIL. All right. The bottom two, the colposcopy, the Ask H and the HSIL, those are more serious. So when we have a less serious finding on the Pap smear, we're going to be less invasive in what we do. The cytology repeated in 1 year, and the HPV DNA testing is non-invasive. And that is appropriate for less serious lesions, such as ascus and LSIL. The ASK-H and the HSIL are more serious in severity, and that's why we will do invasive procedures. Now, the non-invasive is repeat the cytology and HPV DNA testing. The invasive is to do a colposcopy and visual biopsies, or you may cut off the entire transformation zone using a leap. Okay, so let's look at this. This is the least severe abnormality. Ask us. At any age, you can do either repeat cytology, year, or you can do HPV DNA testing. So ask us, the management is not related to age. And it is either repeat cytology or HPV DNA. The LSIL, if she is young, 21 to 24, repeat the cytology. If she is 25 to 64, then you do the HPV DNA testing. These are both non-invasive, but you can see how we have a difference in how we handle the LSIL based upon the age. Okay, let's look down here. The Ask Age, any age, colposcopy and biopsies. Okay, colposcopy and biopsies. You don't do an immediate leap. But if it is HSIL, at any age, you can do colposcopy. So that would be age 21 to 24 and 25 to 64. But if she is older, our concern is higher, and we may just skip the colposcopy and biopsies and go to an immediate leap. Are you with me on that? Spend some time working through this, because this is going to be so helpful on the exam. Age 21 to 24, we're going to do the cytology and not the HPV DNA testing. If she is 21 to 24, we will not do a leap. So I've got the cross through here. Are you with me on that? Okay, this will, some of this stuff can get pretty heavy duty and very complex and very detailed. If you just follow this on the exam, I think you will do okay. So less serious, ask us LSIL. More serious, ask HSIL. At any age, ask us. We can do either cytology or HPV DNA testing. But if she is LSIL, we'll go more to the repeat cytology and not to the HPV DNA testing. But if she's older, we'll do the HPV DNA testing. All right. We talked already about this, endocervical curettage. We will do this if we have a metaplastic epithelium, normal appearing epithelium going into the endocervical canal. So it is to screen for unseen lesions if because part of the transformation zone goes into endocervical canal. The risks of endocervical curettage in terms of future fertility or in cervical insufficiency, that's not a problem. This does not remove any of the cervical stroma. There's no risk of scarring with endocervical curettage. But this is sent separately. Okay, the ectocervical biopsy. On the outer part of the cervix, we're looking for 4 kinds of abnormal epithelium. We're looking for mosaicism. I'll share what that looks like in just a minute. Punctation, white epithelium, abnormal vessels. So when we look for the exocervical specimen, it could be mosaicism, punctation, white epithelium, or abnormal vessels. Which do you think is the most concerning? Which is the more concerning? Mosaicism, punctation, white epithelium, or abnormal vessels? The most concerning is, let's see if you get it right, it's abnormal vessels. This is much more concerning if you have some vessels which are small and others are out of control, big vessels. I'll show you a picture of that coming up. All right, this is an artist's conception of what you would see under colposcopic magnification. Actually, let me show you this one here. It is exactly the same as this one. But let me just point out to you that this is a new squamocolumnar junction. The old squamocolumnar junction was undoubtedly out here. And you can see that this is developing in the T-zone. That's in the T-zone. Okay, so what do we have here? This is probably just a little condyloma. HPV can cause condyloma. White epithelium here, mosaicism here, punctation over here. What causes these pattern changes here? Punctation and mosaicism. And is probably the capillary loops, which are changed by the surface epithelium. So this is what you would see as a result of changes in the capillaries. Here, there's no question. We've got a certain kind of epithelium here, and here we have a different one. You can see the margin goes all the way around. And what you want to pick on your biopsy is the worst looking area. The one which is the thickest, which is the whitest. Take the worst looking areas. But you can see this covers a lot of the cervix, and this is the old transformation zone. This is looking at abnormal vessels. Some of these are pretty big, and some of them are pretty tiny. What cancer will show is failure of control growth. It is growth out of control. And so you have large vessels, you have small vessels, and that's typically what you're going to see with cancer. This is frank invasive cervical cancer, which means that it has penetrated 5 millimeters or more from the basement membrane. Frankly invasive cancer. Here we do a exocervical biopsy, and by looking directly, visually, with the colposcope, you can put your instrument in and you can take a exocervical biopsy right over the area where you can see the abnormal epithelium. This is called the Kevorkian biopsy forceps, and you can see we've got a specimen from 9 o'clock and from 6 o'clock and from 3 o'clock. Okay, so this would be, sometimes it's called a 4-quadrant biopsy. 12, 3, 6, and 9. Okay, we've done the pap smear, we've done the biopsy, and now we want to compare, do they agree? And this is what we already looked at. LSIL should be SIN 1, HSIL should be SIN 2 or 3, and cancer should be invasive cancer. What if you have HSIL on the cytology, but the histology shows only SIN 1? What if you have cancer, which looks like the cytology, but on the biopsy, there's only SIN 2 or 3? That is where the pap smear is worse than the biopsy. And now we need to do a transformation zone because you couldn't find it by looking. So now we just take it all off. It's more of a shotgun approach, which we don't like to do. All right, if a lesion enters the endocervical canal, not the metaplastic epithelium, but a white epithelium or most vessels, that's when we do a deep and narrow cone biopsy. And here is our old squamocolumnar junction in red. Here is our new squamocolumnar junction over here. We would like to see the endocervical canal completely clear, but it's not clear. There's white epithelium going into the canal. You don't know how far down it goes. You don't know if it is invasive, whether it's broken through the basement membrane. So now we need to do a narrow and deep cone biopsy. Here you can see the endocervical canal, and here you can see a lesion which is going down into the canal. I don't like to see that. So that's when we do our cone biopsies. And here you can see a lesion is going into the canal. You cannot tell how deep it has gone, so you need to do a cone biopsy that looks like this. And you can appreciate if you take a lot of the stroma out, what will that do to the strength of the cervix? So this is a cold knife cone. I showed you this yesterday. This would be indication for endocervical curettage. This is metaplastic normal epithelium and possible risks of a deep cone biopsy, cervical insufficiency, and cervical stenosis. We'll talk more about that probably on Thursday. All right, management by histology. This is in your book on page 174. All right, what do we have here? We have as options for management, observation, which is non-invasive. Repeat the pap smear, colposcopy, and pap smear HBV DNA. Or we can ablate, which is destroy the epithelium. You can destroy it using cryotherapy. I showed you that yesterday. Lower the temperature to below 100, below zero. You can vaporize it using a laser, or you can use a Bovie electrocautery and fry it out. Then you can do an excision procedure, which is the LEAP electrosurgical excision procedure, or you could do a cold knife cone. Here we actually cut the area out and we can send it to pathology. Hysterectomy is not a primary management. It is only recurrent symptom. Two or three. What do we do? Repeat pap, colposcopy, and pap smear. That is the most common. Cryotherapy and LEAP would be the most common ablative and excisional procedures. What would you do if you have a SIN 1? That is a third of the epithelium is filled with basal cells. The options: observation, ablation, excision. Why do we say you could just observe? Because a lot of this will go away on its own, even though it is SIN 1. If it is SIN 2 or 3, this is worse. The likelihood of spontaneous reversion is less, although it's still present. So we don't have observation as an option for SIN 2 or 3. it will either be ablation, and the most common ablation is cryotherapy, or it would be a LEEP. Okay, you got that? This is important. We have 3 options with SIN 1. We have only 2 options with SIN 2 or 3. This is looking at what percentage of SIN 1 will spontaneously regress. And you can see there is more regression with SIN 1, 65%, which is 2/3. With SIN 2, 40%. Even with SIN 3, SIN 3 is almost spontaneous regression rate is even higher. This is an article looking at antepartum SIN 2 or 3. SIN 2 or 3, this is either 50% or more involvement. 70% of this will regress postpartum. So that's a huge number of even severe dysplasia will spontaneously reverse after the pregnancy is gone. So that's why we don't get aggressive in our cryo and in our LEEPs during pregnancy. We talked about ablation. The most common one is cryotherapy. We talked about excision. The most common one is LEEP. And then the conization we talked about. This is the wide and shallow cone biopsy. So to summarize, Okay, welcome back for the second hour, and we're talking about the pap smears. This is my email. If you'd like to send me an email, esakala, ESAKALA at LLU.edu. Okay, that was talking about pap smears and hopefully dysplasia. Now we need to talk about invasive cervical cancer. I wrote down here in 1950, cervical cancer was the most common cancer cause of death in women. 250 women every year died. In the US today, 11,000 cases per year with 4,000 deaths per year. But 15 to 19-year-old women, the rate is only 1 to 2 per million. That's why we don't want to get too aggressive. Searching out HPV when the likelihood of finding something is so low, we're causing more harm than we are good. Okay, let's look at our case. A 43-year-old woman complains of intermenstrual postcoital spotting for the past 6 months between regular menstrual cycles, which occur every 28 days. Now, that's a long sentence. Let's break it down and see what it's got. There's two kinds of bleeding. There is regular menstrual cycles, which occur every 28 days. You got that? Regular menstrual cycles occurring every 28 days. And then there is intermenstrual postcoital bleeding. So bleeding which occurs after intercourse, but it is between regular menstrual cycles. That is a classic description of a lower genital tract lesion or even an upper genital tract lesion. So we'll talk more about that in just a minute. I want you to notice her age. She's 43. She is premenopausal. Cervical cancer is the only gynecologic cancer which generally is a premenopausal woman. Okay, on exam, a 3-centimeter exophytic mass is seen on the anterior lip of the cervix. I'll show you what that looks like. The rest of the pelvic exam, including the rectovaginal exam, is normal. Sure, other than cancer, you're looking normal. All right, there's 3 kinds of bleeding patterns that I want to point out to you. And this is week 1, 2, 3, 4. This is the month 1, 2, 3, 4, the second month. Here we've got bleeding which occurs the first week. Bleeding which occurs the first week. Bleeding which occurs the first week. It is predictable in terms of duration, in terms of length, in terms of frequency. The red indicates that there is cramping associated with it. And ovulatory cycles, you would expect to have cramping because they occur as a result of ovulation, progesterone production. When progesterone falls, you have spiral arteriolar spasm, release of prostaglandins, and cramping. That's our first line. Second is what we just talked about. Here we've got regular menstrual cycles right here. But between the regular menstrual cycles, we have unpredictable bleeding. And that's in black. And there is no cramping associated with this bleeding in between. The third line, there is no red at all. There is no predictability at all. There is variation in terms of amount of bleeding, in terms of duration of bleeding, and frequency. This last line is consistent with a hormonal problem, specifically anovulation. This pattern here is associated with an anatomic lesion. It could be a cervical lesion, it could be a vaginal lesion, it could be an endometrial lesion. And when you read the history on the exam of a woman who is having bleeding problems, you've got to look for that. Is there cramping? Is there regularity? Is there irregularity? All right. I've given you this on the handout to show you the 2 slides which I think are important, or the 2 patterns. When you have regular menstrual cycles in red and unpredictable bleeding in between, that is consistent with an anatomic lesion. So we need to do a speculum exam to see if there is a vaginal or cervical lesion. And if there is none, then we need to look up in the uterus to see if there is a polyp or a submucous myoma. Unpredictable, irregular bleeding in terms of amount, in terms of duration, is much more consistent with a hormonal problem, specifically anovulation, unpredictable and irregular, and there's no cramping. Important point to remember. Okay, this is the cervix looking through the speculum. Here you can see an anterior lesion, and it's bleeding. I still think you need to do the biopsy in order to make the diagnosis. But I don't like this. This is invasive squamous cell carcinoma. This is invasive squamous cell carcinoma as well. The most common symptom is postcoital bleeding, bleeding after intercourse, and that was the case that we just went over. The average age is 45 years. The diagnosis I just mentioned is with a biopsy. You've got to do a biopsy anytime to make a diagnosis. And then once you have the diagnosis, invasive cancer because the basement membrane is broken, then you need to do staging. Staging says how far has it gone? Is it limited to the organ, stage 1? Is it immediately adjacent, which is stage 2? Is it involving the lymph nodes, which is stage 3? Or is it distant metastasis, which is stage 4? And obviously, you'd like to have something which is low stage, not high stage. Okay, let's look at our case. Oh, we already looked at the case. I wonder, this is kind of out of, we looked at the case. Okay, let me show you my cartoonish drawing of the continuum between dysplasia and cancer. This is the epithelium we have right here. Here are the basal cells. This is the basement membrane right here. Underneath is stroma. What happens is, as the basal cells start to proliferate, they come from the bottom up. If they involve about 1/3 of the thickness, we call it Sin 1 or mild dysplasia. If it involves 50% or thereabouts of the thickness, we call that Sin 2 or moderate dysplasia. If it involves almost all the way through or all the way through, we call that Sin 3, severe dysplasia or carcinoma in situ. Now, what is the next step that's going to occur in severity? The basement membrane will be broken. And you can see that these cells break through. And when they break through, they now have the opportunity to get into the lymphatics and the vascular system. And so we can have distant metastasis. That is invasive cancer. Do you get the idea? Okay. This is a tragic story of a British reality TV star, 27 years old, who died of stage 4 cervical cancer. The tragedy of this was she had an abnormal pap smear. She was given a notice, please come in, we need to follow it up. And she was basically in denial. And it went for a few years before she finally went in. And then it was stage 4 and she died. Tragic. Okay, I already mentioned that the important management decision will be based on staging. Now, we make a diagnosis of invasive cancer of the cervix by doing a biopsy and make sure that the basement membrane is broken. But then it is clinically staged. So the diagnostic test, cervical biopsy, metastatic workup, imaging studies. But the staging is done clinically. So when we look at stage 1, 2, and 3, as I said, limited to the organ, adjacent, further spread, and further spread. And stage 0 is carcinoma in situ, which really should not be called cancer because it hasn't gone through the basement membrane. Now, this is in your book on page 175. And what do? Do you put this in your brain? Do you try to remember it? If you got room, I would do it. But I would ask you, what's the most common stage? The most common stage of diagnosis is stage 1. So we will look a little bit more at stage 1. This is only clinical staging. There is no hysterectomy. To do endometrial cancer staging, we need to take out the uterus. But with cervical, it is only clinical. And so you look to see, is the invasion less than 3 millimeters? Is it between 3 and 5 millimeters, or is it more than 5 millimeters? If it is more than 5 millimeters, then you need to look. Has it spread to the cervix? Has it spread to the 2/3 of the vagina? Has it spread to the parametria? Has it gone to the pelvic sidewall? And that will then be the basis of your staging. Now, you can do a intravenous pyelogram and look to see if there's hydronephrosis. And if you have blockage of the ureters, which is the most common advanced stage cervical cancer, it blocks the ureters and they go into uremia. Okay, here you can see it has gone anteriorly to the bladder. It's gone posterior to the rectum. This is stage 4. I already showed you this, the staging. Stage 1 is involving the cervix only. This is where you do a simple hysterectomy. Stage 2, it has gone partially out into the broad ligament. All right, just to say what I already said, which is in the book, if it is stage 0, the basement membrane is intact. This is the basement membrane, no invasion at all. If it has gone through the basement membrane, but less than 3 millimeters, that is stage 1A1. That is called minimally invasive. If it's gone more than 3, but less than 5, we call that stage 1A2. And if it's gone more than 5, we call that 1B. Why is this so important? Because the aggressiveness of your therapy is going to be determined by the stage and how advanced that is. Let's look at that. This is on page 175. We can look at stage 1A1, total simple hysterectomy. That could be either vaginal or abdominal. Stage 1A2, modified radical hysterectomy. This is between 3 and 5 millimeters. Stage 1B or 2A can be either radical hysterectomy in a premenopausal woman or postmenopausal. You could do a radiation therapy. And if it is more than 2B, it's radiation therapy and chemo for all ages. This is on page 175 in your book. Stage 1A1, less than 3 millimeters, minimally invasive, management, simple hysterectomy. Stage 1A2, between 3 and 5 millimeters, microinvasion is going to be modified radical. And stage 1B, over 5 millimeters, frank invasion, radical hysterectomy. And that's on page 175 in your book. And I think this might be worth putting in your brain because the most common stage with cervical cancer is stage 1. We've already looked at 5-year survival looking at stage with vulvar cancer. And the same thing holds true with cervical cancer. The more advanced the stage, as we move this way to the right, the survival gets less and less. And that would be expected. This is Evita Duarte Perón. This is actually Madonna, I believe, here. Evita was the wife of Juan Perón, who was the president of Argentina. What's interesting is that Evita died at age 33 of invasive cervical cancer, stage 3. What's also interesting is that his first wife also died of cervical cancer at about the same age. Very interesting. Suggesting that he had a very virulent HPV, which caused the death of these young women. And when Evita died, it was interesting. They did a radical hysterectomy. They brought down a surgeon from the United States, I think from Sloan Kettering Hospital. I don't know why you would do a radical hysterectomy on stage 3. There is some people who say that she didn't even know, she wasn't told that she had a stage 3 cancer and that she didn't even know she was going to die. But when she died, it was a big issue there because she was really well liked by the population. Okay, let's look at cervical neoplasia in pregnancy. A 25-year-old woman with intrauterine pregnancy at 14 weeks by dates is referred for a pap smear of HSIL. We already talked about that. Pelvic exam, a gravid uterus, 14-week size, and the cervix is grossly normal. Now, what did we say would be the management with HSIL? The management with HSIL at any age is going to be colposcopy and biopsies. Typically, that's what we're going to do. Now, in pregnancy, we don't, because the likelihood of regression is so high. What is the effect of pregnancy on the progression of cervical neoplasia? No change. No change. Because, some cancers are hormonally driven. And when the estrogens go up, it grows faster, and breast cancer is one of those. Do we do colposcopy and biopsies? Yes, if we need to. But most commonly what happens with cervical dysplasia in pregnancy, she will see a experienced colposcopist who will look and will say, I don't think that's invasive. Let's just repeat the colposcopy every trimester. Do we do endocervical curettage? Not routinely, only if a lesion goes into the canal. As always, the diagnosis is based upon a biopsy, and the management will be based on staging. So when we have cervical intraepithelial neoplasia, when we have just dysplasia, we will typically just observe. We won't do any leaps. We won't do any cryo. And remember what I said? That 70% of SIN2 and 3 in pregnancy will disappear spontaneously by the immune system after the pregnancy is over. Now, if it's microinvasion is between 3 and 5 millimeters, stage 1A2, we might just do a cone biopsy and see if we can cut it out. Now, is there going to be extra bleeding? You bet there'll be more bleeding because she's pregnant, because there's increase in the vascularity. But if it is frank invasion, if it is more than 5 millimeters, that becomes problematic. And the bottom line is this. If she is pre-viable, and we can arbitrarily say that viability is around 24 weeks. If she is less than 24 weeks, the recommendation to ignore the pregnancy and treat the cancer. So let's say she had stage 3 cervical cancer at age 18 weeks. Stage 3, you're going to do radiation therapy. What's radiation therapy going to do to the fetus? It's going to die, go into labor, and she will expel it. Let's say she has stage 2, that's 18 weeks. That you could do a radical hysterectomy. So you do a radical hysterectomy of a pregnant woman. If she is viable, and viability will say over 24 weeks, then we might want to wait to 32 weeks, give some beta-methasone, give some magnesium sulfate for neuroprotection, deliver, and then do your radical hysterectomy or do your radiation therapy or whatever you need to do. Now, I don't think they're going to give you an exam question which says 24 weeks. They're more likely going to say 16 weeks and say 30 weeks. And that'll be pretty straightforward then. But this is an example of a radical abdominal hysterectomy with a fetus in situ. Here you can see the shoulder and the head and the arms. This is a tough decision for a mom to make. But see, the idea is if you don't do any therapy and if you wait, could you lose the mother as well as the fetus? So that becomes a real ethical dilemma. Okay. So we've talked about dysplasia, we've talked about invasive cancer. Let's look about prevention. What can we do to prevent cervical cancer? And we can give the immunization, the HPV immunization. This is Gardasil. This is a quadrivalent human papillomavirus recombinant vaccine. And it is quadrivalent, quad meaning four, for the four DNA types, 6 and 11, which would be to prevent the condyloma acuminata, which is to prevent most of the invasive cancers. Now, I thought it was kind of interesting the name that they picked, Gardasil. I wish I had thought of this, because if you look at the construction of this word, guarding against squamous intraepithelial lesion. Huh? What do you think? I think it's kind of clever. Now, there is a competitor, cervix, which is a bivalent. It has only 16 and 18. Now, I don't know why you would choose this, which protects against only 2, rather than 4. But there's been no head-to-head studies to compare these. So how much does it cost? It's about $300 to $400. There's 3 injections which are given. The Center for Disease Control supports cervical cancer vaccination for girls and young women. All right, I have summarized what is in the book, which is on page 177. Okay, Amanda, if you could get the embryology video ready pretty soon, and we may use that. Okay, so what do we say? Between now, you can give it as early as 8 or 9. You can go to as least target age is 11. Do you need to do HPV testing beforehand? No. Do you need to pap smear? Yes, you do, because you could have a cervical dysplasia, which is other than 6, 11, 16, and 18. Is it okay if she is already sexually active? Yes, it is. Is it okay for previous cervical intraepithelial neoplasia? Yes, it is, because those could have been from a different HPV DNA type. Now, it isn't okay to pregnancy, but if it was given and then she finds out she was pregnant, this is not an attenuated live virus. It uses virus-like particles, which are alive. And so there's no need to consider abortion. It is not recommended in pregnancy, but it is okay if it happens to be given. It's more of a theoretical concern. All right, and this is on page 177 in your notes and talks about what I just said. How about for males? Should males be also immunized? And the FDA is now recommending males between 9 to 26 to be also immunized. Now, if there were enough females that were immunized, if there were over 80%, at least this is what the statisticians come up with, there's no need to immunize the males because there is enough herd immunity, if you know what I'm talking about. But otherwise, it would be proper to immunize the males. This is from Australia, large study looking at 50% reduction in HPV in teen girls with HPV vaccine. Does it work? It sure looks like it does. HPV, a vaccine helps protect against more than just the 6, 11, 18. Now, there are those who say, my daughter got HPV injection and she died from it. And so they're against immunization. What do you think of that? The following girls and women died after receiving Gardasil. Well, the largest study where they looked at 26 million immunizations, 9,000 non-serious events. Patient got hypotensive, she passed out, or you had some local irritation. 585 serious events, 20 deaths, but when they looked at the cause, they did autopsy. There was no evidence of any relationship to the vaccine. So at this point, it looks like it is still recommended. HPV may be linked to lung cancer. By immunizing against HPV, could be preventing lung cancer. Anal cancer can be also caused by HPV DNA type 16 and 18. There is now a big issue with anal dysplasia, and Gardasil has been approved to include the prevention of anal cancer from anal intercourse. Okay, so that is Mullerian anomalies. That is prevention. Now I want to move to Mullerian anomalies. The uterus and the cervix and the tubes arose from the Mullerian duct. All right, remember there's two Mullerian ducts. One comes from one side, the other one comes from the other side. They fuse together. And there is obviously going to be a septum where they fused. That septum needs to dissolve. You can see the septum is gone here. And we then have, as a result, from the Mullerian system, the proximal vagina, the cervix of the uterus, the corpus of the uterus, and the fallopian tubes. Okay, Amanda, if we can put on that video clip, and this shows very nicely how this all works. Okay, the red here is the Mullerian duct from the left side and from the right side. This is the urogenital sinus. Now watch as we roll the action. Can you see we're getting fusion of the ducts? And here we have the septum. The next thing that's going to happen is the septum is going to disappear. And you can see we have no septum now. One next going to happen is we're going to see the cervix develop here, and the proximal vagina will come here. See, the vagina is derived from the Mullerian system proximally and the urogenital sinus distally. So watch carefully. Can you see the cervix is beginning to form right here? I love it. This is a great video clip, and you can see how it describes it very well. So I'm going to let this just play on its own. Okay, thanks. We can put that off to the side. Amanda. Okay, let's look at the possibilities as to what could happen. We can have uterine anomalies from failure to form. You have failure to form either both ducts one duct or part of a duct. So these are failure to form or formation problems. Then you can have a problem from failure to fuse, where they don't come together. They're both there, but they don't come together. We don't have fusion, either of the entire or part of the ducts. And then the third is failure to dissolve of the entire septum or a portion of the septum. All right, and this is in your book on page 177 and 178. Failure to form, hypoplasia, agenesis, unicornuate uterus, failure to fuse, didelphys and bicornuate uterus, and failure to dissolve the septum, septate and arcuate uterus. So let's look at some pictures here. Okay, here we have failure to form an entire side. We only have the right side, which is here. So we have the right tube, the right uterus, the right cervix, and the vagina, but there's nothing on the left. So what are the problems here? There's no problem in fertility because ovulation can occur, the tube can bring down the egg, we can have sperm that comes up, fertilization occurs. But the problem is the uterus is very small. It starts stretching very early. The stretch of the uterus sends a signal it's time to go into labor, and these women will typically deliver babies that are so small, they're so early that they don't survive. And there is no therapy. You can't fix this. With a unicornuate uterus, you're stuck with what you got. Now here is a didelphys uterus. You hear, so both of them formed, but they didn't fuse. So we have two cervixes. We have two vaginas, two uteruses and two fallopian tubes. Now, what you can do here is the same problem can develop as here, where if you have a pregnancy on one side or the other, it goes into premature labor and delivers so early it can't survive. But what you can do here is you can surgically remove the medial part of this horn of the uterus, the medial part of this horn of the uterus, and you can bring it together. So you can create a uterus. Now, obviously, this is at high risk for rupture in labor, so we would want to do a scheduled cesarean. This is a unicornuate uterus. This is a didelphys uterus. Let's look at a bicornuate uterus. Now, here we have formation on both sides. We have partial fusion, but here we have a septum, and it is a thick septum. Now, what happens here is we've got, sometimes you can have the baby on one side, you can have the placenta on the other side. Malpresentation is very common. 50% of these will also go into labor early. But this can be surgically removed, and we can bring this together with a normal appearing uterus. Can you see this has a very narrow septum? This has a thick septum. If you have implantation on this septum, you've got pretty good blood supply. But if you have implantation on a very narrow septum, it will easily resected hysteroscopically. You can resect the septate uterus. So here we have the unicornuate, the didelphys, the bicornuate, and the septate. Failure to form, unicornuate uterus. Failure to fuse, a bicornuate or a didelphic uterus. This is a bicornuate uterus. The fetus was in this horn. The placenta was in this horn. And compare the appearance of this uterus and this uterus over here. You can see this is kind of a heart-shaped uterus. And this was a malpresentation. This was a breech presentation. Now, we knew she had a bicornuate uterus from before, but every time I do a cesarean, because of a malpresentation, I want to check to see if the uterus is normal. Now, I want you to look at the fetus as well. What's going on here? This is a deformation. This leg got twisted because it didn't have enough room inside. Now, this is not a malformation. This is a deformation, and the pediatric orthopedist could cast this, and it was subsequently adequately taken care of. But this is because of pressure, because you don't have enough room in that one side. And then you have the failure to dissolve. So we have failure of form, failure to fuse, failure to dissolve. Form, fuse, dissolve. These are the 7 categories of uterine anomalies according to the American Fertility Society. And they are based. Okay, the enlarged uterus, page 179. What cause of an enlarged uterus in the reproductive years? Don't miss this one. Exactly. Pregnancy. Next step in management, beta HCG. On the exam, you have a patient who comes in with an enlarged uterus. Doctor, I've never had sex. I can't be pregnant. The next step in management, beta HCG. I've seen many patients who have come in who are at term in labor and who say, I never had sex. Right. Okay, if she's not pregnant, it could be a leiomyoma. If it's not a leiomyoma, it could be adenomyosis, and we're going to look at that in some detail. A leiomyosarcoma is a malignant, smooth muscle tumor. The likelihood of a leiomyoma degenerating into a leiomyosarcoma is only 1 in 1,000. It is very rare. So we don't look at leiomyomas as being precancerous. And this is so rare, I'm not even going to talk about it. I don't think they're going to ask any questions on the exam. But remember, the most common cause of an enlarged uterus in the reproductive years is pregnancy, next step in management, beta HCG. All right, this is an ultrasound, and this is a pelvic ultrasound. And we can see that there is some sort of mass, seems fairly homogeneous, which appears to be encapsulated, which measures 8 by 9.5 centimeters in size. This is a classic ultrasound appearance of a leiomyoma. This right here. Smooth muscle, tumor benign. When you look at where could these leiomyomas be located, I'm going to show you using this little diagram that I put together. We can have intramural, which is in the wall of the uterus. They could be under the mucosa of the uterine cavity, the submucosa. They could be pedunculated on a stalk, or they could be subserous under the outer lining of the uterus. So this would be a subserosal. This would be a leiomyoma, which causes the uterus to be lumpy and bumpy. This is in the wall of the uterus. This is in the wall. We call this intramural. The patient doesn't even know it's there. You won't see this on imaging. I suspect many of you ladies who are on the course tonight have leiomyomas within the wall of your uterus, and you don't even know that they're doing anything. And they're just sitting there minding their own business. Then we can have a leiomyoma, which is in the submucosal area. This deforms the uterine cavity. Oh, let me just go back one. What would happen if you had implantation of an embryo onto a submucous leiomyoma? You wouldn't have as good blood supply, and you could very well have a second trimester pregnancy loss. This is a pedunculated subserosal leiomyoma. This would also make it lumpy bumpy. You can see how easy it is to take this off just with a suture, and it's not going to be bloody at all. This is a pedunculated submucosal leiomyoma, and this could be easily hysteroscopically resected, and so could this one here. Now, what kind of location would be more predisposing to bleeding? And that would be with the submucosal leiomyomas, which can bleed, and we'll talk about that more later. So this gives you the locations of the leiomyomas. This is an incredible picture. This is a uterus, and you can see these subserosal pedunculated. This is a pretty thick base here. This is the round ligament down over here. Huge leiomyomas. Now, this could be, if they impinge on the uterine cavity, cause problems with infertility. It could also cause problems with preterm labor and obstruction. This uterus exists only in the mind of the artist, but it shows leiomyomas everywhere that they could possibly be. This is a subserosal pedunculated. Here's a submucosal pedunculated. This is an intramural. This one is a subserosal. This is an interligamentous. This can sometimes be presenting as an adnexal mass. And this one is prolapsing through the cervix. What is a natural history for leiomyomas? Usually they grow slow. Most of them will grow slow. You don't need to manage them. Just leave them alone. You don't need to do a biopsy. They can grow in size when hormone levels, particularly estrogen, go high, and that can happen during pregnancy. The growth in that leiomyoma can be so rapid, it outgrows the blood supply and degenerates, in which case we call this red or carneous degeneration. What are the symptoms? Pain, pain. Doctor, I need morphine. I need meperidine. I need Demerol. What do? You hospitalize them and you give them morphine and you give them Demerol. Leiomyomas are more commonly seen in Black women, 5 times more commonly than in Caucasian women. And when they are large during pregnancy, they can undergo degeneration. Now, when the hormones fall after menopause, they can decrease in size as well. So they can be hormonally stimulated. We can also reduce the size of the leiomyomas by using a medicine, a leuprolide, a GnRH agonist, to lower the FSH and lower the estrogen levels. And then they will decrease in size as well. Here we have what happens with the degeneration. You can have either calcification and you have calciferous degeneration. Here you can have cystic degeneration. And I have done hysterectomies on women who have uteruses like this, and I didn't know that they were cystic degeneration. We didn't have ultrasound at that time. And when I grasped the uterus here, my thumb went down into the inside here, and out came a green yogurt-like viscous fluid, which is the grunch from the degeneration. This is an interesting case, an 88-year-old woman who was in a nursing home who was brought to the emergency department with upper GI bleeding. They did a flat plate of the abdomen. They looked and saw this round, homogeneous, painless, non-pulsating suprapubic mass. What do you think it is? I think it's a calcified leiomyoma. Now, she's 88. When do you think she was pregnant? Got to be at least 40 years ago, probably, maybe even 50 years ago. And it's just sitting there, not causing any problem. Just leave it alone. All right, the diagnosis of leiomyomas. On pelvic exam, lumpy bumpy. That would be typical of what you would find. This would be with a subserosal. Now, a sonogram, you can do an abdominal sonogram, you can do a vaginal sonogram, depending on the size and the location of the leiomyomas. Hysteroscopy would be best to look at and to resect a submucosal leiomyoma. And we're going to do that probably after the break, and we're going to look at some of the video clips. The diagnosis is based on histology ultimately, and this would be if you do a total abdominal hysterectomy, a total vaginal hysterectomy, you could do a myomectomy, but most of the time it's a clinical diagnosis made by exam and by looking at an imaging study, and you don't need histology. You can look at intra or submucosal leiomyomas using a saline sonogram, sometimes called saline infusion sonography. and you put a catheter into the uterus. You instill 5 to 10 cc's of saline, which pushes the walls apart. You have an intravaginal probe of ultrasound, and then you can look. And here you can see is the saline, which is pushing the walls of the uterus apart. You can actually measure the endometrial thickness on either side, and you can see there is no lesion here. Here, it doesn't take a rocket scientist to see that there are lesions. Now, what are they? I don't know. The saline sonogram is helpful in diagnosing, but it's not in removing and treating it. So hysteroscopy, the nice thing about hysteroscopy is you can not only see it, you can also remove it. And this can be done hysteroscopically like this. I'll show you some pictures after the break. This is an artist's conception of intracavitary leiomyomas fibroids. You can see this one almost fills the entire uterine cavity. This is in your book on page 180, and it shows the saline sonogram. Here is the catheter, which is coming in through the cervix, and this is fluid pushing apart the walls of the endometrium. And here's another image showing the saline sonogram. Okay, and I think we'll take our second break right here. And Amanda, after the break, we will bring on the subserosal and submucosal leiomyoma video clips. There's 4 of those. Okay, see you in 10 minutes. Okay, here we are for the third hour, and we're talking about leiomyomas, and let's look at the management. Most of the time, observation, just serial pelvic exams. If it is so big that it completely fills the pelvis, that makes it difficult to feel for the ovaries. But normally, you're not going to have it that big. So observation, most of the time, loprolide is a GnRH agonist. It will stimulate initially the receptors for GnRH, and then it'll block them. The FSH levels will drop, estrogen will drop, and there will be shrinkage of the tumor. And this can be used for pre-surgical shrinkage to minimize blood loss. Myomectomy could be used if a patient wishes to keep fertility. And that one uterus that I showed with the many, many leiomyomas, myomectomy would be the only way that she could keep her fertility. Embolization is something which you can use, and I'll show you how this works. This is done by interventional radiology, and one can retain the uterus that way. In terms of fertility, I'm not sure that's a very high likelihood of keeping, although it can occur. I wouldn't do embolization if you wanted to have more children. The definitive treatment would be hysterectomy, and that would remove it completely if fertility is gone. Okay, on page 182, it really goes through what I just said, only in a tabular fashion. Okay, when we look at myomectomy, here we have a fairly large subserosal leiomyoma. It's got a fairly thick base here. And this is a laparoscopic myomectomy. If the uterine cavity is entered, it increases the risk of uterine rupture. But if it's not entered, it is okay. Now here you can see is a fairly uncommon shaped uterus. This is the round ligament here. This is the fallopian tube. This is the fallopian tube here, the round ligament over here. Look at the difference in size before and after the resection. This is the uterosacral ligaments, which are down here, and this is the cul-de-sac. Now you can see this is a vertical incision, looks kind of like a classical uterine incision, and I think she probably needs to have a cesarean delivery when she gets pregnant. Okay, let's see if we can look at our video clips. And the first one we'll look at is a subserosal small. So let's see if we can put that one up. As I said, most of these are benign and can be left alone and don't cause any problem. If they are submucosal, such as this one down here, they can bleed. You can see this one, this is the leiomyoma, is almost the same size as the uterus. And this is a intracavitary submucous leiomyoma that we're going to see if we can resect. Let's see if we can get our videos uploaded here. I'm going to sneak on forward, and when we get the videos, Amanda, we can go ahead and put them up. This is uterine artery embolization. And you can see you put a catheter in through the femoral vessels here, actually it's the iliacs, and you come down and you go through the internal iliac and you go into the uterine artery here. This shows probably a little better. Now what you do is you have microspheres. These are about 8 micron size, the polyvinyl microspheres, and you inject those through the catheter. And the idea is that they will go in and obstruct the blood supply. They will obstruct the capillaries, which will cause ischemia. Ischemia will cause them then to degenerate and to shrink. what sort of symptoms do you think they would have? Pain, a lot of pain. Now, if you get these into the wrong vessels, what could happen? You could have, for instance, ovarian failure, and 15% premature ovarian failure can happen with these. And this is done by interventional radiology, as I said. They are pretty successful, 90% successful, 10% failure rate here, at least according to this study. This shows the size of a uterus with a leiomyoma, 18-week size. That's almost up to the belly button. And the dotted white line shows the size. Now, after the embolization is this solid black line, which you can see here. So it is reduced by height about 40%. And if you reduce it from all directions, you can see you've got a significant reduction. This was a very important lady, Condoleezza Rice, who was President Bush's Secretary of State. And in this article, it says that Rice is out of surgery and resting comfortably after undergoing a successful uterine fibroid embolization at Georgetown University Hospital. Now, I don't think she's married. I don't think she's planning on having any children. By the way, she speaks Russian fluently, and she is a concert pianist. But what happened after the procedure, do you think? The minimally invasive procedure took an hour and a half, was performed by interventional radiologist James Spies. I imagine she had a lot of pain. And that's to be expected because you're really causing an iatrogenic carneus degeneration. This is an interesting device using focused ultrasound transducers to destroy the leiomyoma. I don't have any personal experience with this, but one of the students referred this to me. It's MR focused ultrasound. Okay, let's look at adenomyosis. We have an enlarged uterus, pregnancy. We have an enlarged uterus, leiomyoma. The third reason could be an enlarged uterus because of adenomyosis. Adeno is glands. Myo is in the muscle. So these are glands in the muscle of the uterus. And it is endometrial glands and stroma in the muscle of the uterus. Here's our case. 42-year-old woman complains of increasing pain with menstrual periods for 8 months. Her periods are getting heavier, leaving her tired and weak. She underwent a postpartum tubal ligation after her last child 10 years ago. She's been treated for chronic hypertension for 3 years, probably has nothing to do with what's going on. On pelvic exam, her uterus is 12-week size. Now, 12-week size will completely fill the pelvis. It's a good size uterus. After 12 weeks, it becomes an abdominal organ. Now, if it was a leiomyoma, it would be irregular rather than globular. It would be firm rather than soft. It would be non-tender rather than tender. This is a classic history for adenomyosis. We have a woman in the middle of her reproductive years, growing toward the end. She has increasing pain with menstrual periods. What is the medical term for pain with menstrual periods? Term is not dyspareunia, dysmenorrhea. Okay, is this primary or secondary dysmenorrhea in a 42-year-old woman? This is going to be secondary dysmenorrhea, and we'll be talking more about that later on. So we have a woman with secondary dysmenorrhea. Her periods are getting heavier. She probably is anemic. That's why she's tired and weak. And she has a uterus which is enlarged, globular, soft, and tender. That's a classic description for adenomyosis. This is a histology. This is myometrium. This is soft, smooth muscle over here, smooth muscle here, smooth muscle over here. This dark stuff and these glands is clearly not smooth muscle. This is endometrial stroma and endometrial glands. How did it get into the uterus? How did it get into the uterus? there's many theories, and probably one of the main ones is that the mesoderm, which was totipotential, most of it differentiated into myometrium, but some of it decided it was going to go into endometrial glands and stroma. And so it's just totipotential tissue. The areas, or they call it rests, embryonic rests of tissue, just developed into something other than what it should have. It is typically benign. On exam, globular, diffuse, tender, symmetrically tender uterus. And often it is diffuse throughout the uterine cavity like this. So on page 183, I have given you this comparison of leiomyomas and adenomyosis. Leiomyomas are asymmetric because of the subserosal fibroids. Adenomyosis is symmetric. Leiomyoma is firm. Adenomyosis is soft. Leiomyoma is non-tender. Adenomyosis is tender. So this would help you when you're reading the physical exam on the USMLE2. And it would help direct you to one or the other, more toward a leiomyoma or more toward adenomyosis. So this is what we've got on page 183. This is an MRI of a uterus with adenomyomas. Now, you can see this is a huge uterus. See, this is the sacral promontory. This is the sacrum here. These are the lumbar vertebra. So we're up to the sacral promontory. Can you see how symmetric it is? It's just as thick on this side as it is on this side. Now you can see the endometrial stripe fairly well demarcated right over here. And here we have another one. You can see how symmetrically enlarged it is. The endometrial stripe is not quite as obvious here. Now, the management for adenomyosis historically has been surgical. And primarily, we're looking at bleeding and pain. And if the cause is pain, then still hysterectomy is the way to go. But if it is largely because of increased bleeding, because of the increased area of the endometrial cavity, which is covered by the endometrium, you can use a levonorgestrel intrauterine system, or IUD, called a Mirena. So medical management would be to put this Mirena. The Mirena intrauterine system or intrauterine device has this capsule which contains levonorgestrel. And as that is released, it will stabilize the endometrium and prevent it from bleeding. So medical management would be a levonorgestrel IUD. Okay, so that is the end of the enlarged uterus. How are we looking on these video clips? All right, in the meantime, we'll go on and talk about postmenopausal bleeding. What is your big concern regarding postmenopausal bleeding? Okay, the big concern is endometrial carcinoma. So here's our case. 65-year-old woman complains of vaginal bleeding for 3 months. Her last menstrual period was age 52, and since then she's not had bleeding. So she is 65 now. 13 years ago, she underwent menopause. No bleeding until for the last 3 months. See, that's troubling. And when you have postmenopausal bleeding, you need to think of endometrial cancer. It is the most common gynecologic cancer. She has taken no hormone replacement therapy. See, that would be an issue. Let's say she was on continuous estrogen and she had a uterus. Continuous estrogen can lead to unopposed stimulation of the endometrium. You get endometrial hyperplasia, and next thing you know, you've got cancer. But she's not had any of those. She's had type 2 diabetes mellitus for 20 years. She has chronic hypertension. And epidemiologically, we know that endometrial carcinoma is related to type 2 diabetes and is related to chronic hypertension. Now, I don't know how diabetes can contribute to endometrial cancer. I don't know how chronic hypertension can contribute to endometrial cancer. But the third epidemiologic risk factor is obesity. She is 52 inches tall, 62 inches tall, but weighs 200 pounds. So she's obese. It is the obesity which is a risk factor because the obesity results in extra peripheral adipose. That peripheral adipose can convert adrenal androgens into estrone. And estrone is the dominant estrogen postmenopausal. Now, it just happens that when you have a woman who is older and who is overweight, she goes along for the ride, diabetes and hypertension. So they are associated, but I don't think they are directly related. Now, the physical exam, including a pelvic exam, is normal with no vulvar, vaginal, or cervical lesions. So the uterus is small, is normal. Can you exclude endometrial carcinoma because the uterus is tiny? Is that okay? Could you have endometrial carcinoma in a uterus which is small? You could. So what is the only way we can exclude endometrial carcinoma? What must be our next step in management? We've got to take some sort of histology of the endometrium. And usually an endometrial biopsy will be where we will go. Okay, let's look at our handout. Postmenopausal bleeding. The first thing we need, and I just mentioned that, is some histology. Endometrial biopsy is always needed. Hysteroscopy, if you cannot get an adequate explanation for the bleeding with an endometrial biopsy, then you may need to do a hysteroscopy. But we've got to get tissue from the upper reproductive tract. So we are assuming that we've already done a speculum exam. We're assuming that you don't have a vaginal lesion, we don't have a cervical lesion. And we will manage by histology. So endometrial biopsy and hysteroscopy, if we need it, let's look at how that fits. Now, you also all need to know that there could be non-endometrial lesions which can cause vaginal bleeding. And I just mentioned a lower reproductive tract, a vulvar lesion, vaginal lesion, a cervical lesion. Be sure you do a speculum exam. In fact, that's going to be done even before you do the endometrial biopsy, because you can do that right in your office. It costs nothing. Now, you could have bleeding from the GI tract. The woman has bleeding down there. Where's there? I don't know, down there. What's down there? Well, there's the vagina, but there's also the rectum. Could you have rectal bleeding? You could try a rectal exam, stool guaiac, anoscopy, because the number 2 or number 3 cancer in women is colorectal cancer. Okay, if we do an endometrial biopsy and the endometrial biopsy is benign, now what should you think of? Endometrial atrophy. Now, if a woman has endometrial atrophy, do you think she's going to be a BMI of 40, of 30, of 20? She's going to be a low BMI because she doesn't have much peripheral adipose tissue. So how do you treat endometrial atrophy? You've got to give estrogen. But if you give estrogen only, you can get a endometrial hyperplasia. So we need to give estrogen plus progestin. The most common progestin we use is MPA, medroxyprogesterone acetate. The trade name is Provera. You've probably heard of that. So if you got endometrial atrophy, it's most likely from a low BMI, low estrogen. So we need to give estrogen and progestin. What if the biopsy shows endometrial neoplasia? Endometrial neoplasia would be precancerous. What would we be looking at? We'd be looking at hyperplasia without atypia and hyperplasia with atypia. Now, if there is endometrial hyperplasia with no atypia, that is benign. the likelihood of that going on to endometrial carcinoma is very low. The treatment is progestins, MPA, for 3 to 6 months, and then repeat the biopsy. Make sure it is no longer hyperplastic. But if there is hyperplasia with atypia, now what does atypia mean? Atypia is where you're looking at the nuclei, at the nuclear line, and you have hyperchromatism, you have darkness, you have dark, heavy nuclei. That would be atypia, and that is premalignant. 30% of patients with hyperplasia with atypia will go on to develop cancer. So now we need to do a hysterectomy. It could be a TVH, a total vaginal hysterectomy. It could be a total abdominal hysterectomy, but we can't just wait. Now, it doesn't have to be a staging surgery because it's not cancer yet. Endometrial neoplasia. What if it shows malignancy? If endometrial biopsy shows endometrial carcinoma, now we've got to do staging. The most common endometrial carcinoma is adenocarcinoma. Remember, the cervix, the most common is squamous. Vaginal cancer, the most common is squamous. Vulvar, the most common is squamous. But of the endocervical area, columnar epithelium, it is adeno. Of the endometrium, it is adeno. And if you have carcinoma of the fallopian tube, which is very rare, it's going to be adenocarcinoma. We need to do surgical staging. When you open up the peritoneal cavity, the first thing you do is you pour in some saline and you aspirate it. We call that peritoneal washings. We want to see if there's microscopic metastasis in the peritoneal cavity. And then we will do a TAHBSO, total abdominal hysterectomy, bilateral salpingo oophorectomy. I'll show you some pictures of that. And then, based upon what the stage is, stage 1A, stage 1B, stage 2, stage 3, whatever, we may do chemotherapy. We may give progestin, such as MPA, or we may give radiation. But the cornerstone of therapy with endometrial carcinoma is TAHBSO. Now, what if the endometrial biopsy is benign and you can't find anything and you do a hysteroscopy? And the hysteroscopy is benign. What would be a benign lesion which you would pick up with hysteroscopy that could cause bleeding? It could be a submucous leiomyoma. It could be an endometrial polyp. Those are typically benign, and they can be removed hysteroscopically. So the nice thing about the hysteroscopy is it is not only diagnostic, you can find the lesion, but you can be therapeutic. Now remember, when you do an endometrial biopsy, you are doing it blind. You don't know where the lesion is. You just put in your instrument and you pull it out, and you hope you got it. If a diffuse lesion is present, you will pick it up no matter where you go. But if it is localized, such as a submucous leiomyoma or endometrial polyp, you will have a negative endometrial biopsy, and that's when you need to do the hysteroscopy. So endometrial biopsy, always you start with that, and then hysteroscopy. This is looking at the difference between simple and complex hyperplasia. Simple hyperplasia, you can see there is an equal amount of stroma, which is here, and the glands. When you look at complex hyperplasia, you have decreasing stroma and more glands. Again, looking at the incidence of various kinds of cancer, and the most common one that we're concerned in right now, gynecologically, is endometrial cancer. There's 50,000 new cases a year, twice as many as ovarian, 4 times as many as cervix, 8 times as many as vulvar. Endometrial, what is the most common stage with endometrial cancer? Is it stage 1, stage 2, stage 3, stage 4, when it's picked up? The most common stage is stage, I see stage 2, people saying stage 2, stage 2. It's actually stage 1 because you have bleeding. And so you have early pickup. What is the most common stage with ovarian cancer? The most common ovarian cancer stage is not 1, it's 3. 65% is stage 3. And the reason is because there's no early symptoms or no early indications. Okay, the average age is 61. What's the average age of menopause? 51. So we're looking at endometrial carcinoma starting about 10 years post-menopause. 10 years post-menopause. So it's a slow-growing tumor. If we look at the various causes of postmenopausal bleeding, atrophy, estrogen treatment, endometrial cancer, polyps, hyperplasia, and what other, you can see that endometrial carcinoma is the minority. It's only 15%. And yet it's the most severe. That's why we need to get aggressive in making the diagnosis and appropriate treatment. The pathophysiology is unopposed estrogen. The idea of opposed estrogen is this. Normally, in a reproductive life, when there is elevation of estrogen, there will also be elevation of progesterone. For instance, in a non-pregnant ovulating woman, she will have a rise in estrogen, which will trigger the LH surge. She will have ovulation. Ovulation, the corpus luteum produces progesterone. So we have initially estrogen, and then comes progestin. Estrogen, progestin, because the progestin is a stabilizer. It's the brakes on the engine. Estrogen is the gas pedal, so to speak. If we have pregnancy, we have high levels of estrogen, but we also have high levels of progestin. And so it offsets this. When you have unopposed estrogen, you have excessive hyperstimulation without the stabilizing effect of progesterone. And that is what causes most endometrial cancer. Now, there is type 1 endometrial cancer, is type 2. Type 1 is the one that is typically related to estrogen stimulation. That's probably 80%. 20% is type 2, which is unrelated to estrogen stimulation or hyperplasia. Okay, the risk factors for endometrial cancer, we already talked about this. Obesity and hypertension and diabetes. So it's not the hypertension, it's not the diabetes, it is the obesity with the peripheral adipose, which converts the adrenal androgens into estrogen. The diagnostic test, we already talked about this, endometrial biopsy, that's done on all patients. And if we don't get satisfactory answer with endometrial biopsy, then we do the hysteroscopy. Lynch syndrome, hereditary non-polyposis colorectal carcinoma. These women have very high levels of colorectal cancer. And here you can see this is the general population, and this is women with Lynch syndrome and men with Lynch syndrome, 10 times higher. But look at here, the endometrial cancer. Now, they call it uterine. How much higher is this column than this one here? It looks to me like it is 3, 6, 9, 12, 15. It's 20 times higher. And also ovarian cancer. So you should put this someplace in your brain. Lynch syndrome is associated with higher rates of ovarian cancer, endometrial cancer, and colorectal cancer. All right, we already talked, I think it was yesterday, how the endometrial sampling works. There is this opening on the side of the instrument. You put it into the cervix, into the uterine cavity. You pull back the piston. It creates a suction, and then it will rotate. And as it rotates, it sucks in the surface cells. This is not a biopsy in the sense going deeper to where you get the stroma. This is the surface cell. So it needs to be a diffuse lesion which is present in order to pick this up. If you don't find it with an endometrial biopsy, then you do the hysteroscopy. Now, this is a hysteroscopic view of endometrial atrophy. And you can see how pale the endometrium is here. This is a tubal ostia that goes into the right tube. This is the left tube. You can see perhaps a little bit of bleeding and hemorrhage here. This would be hysteroscopic assessment. Now here we've got something which is almost completely filling the endometrial cavity, but you can see it is clearly demarcated. See that? It has a very discrete edge. That's not cancer. Cancer does not have a discrete edge. This is more consistent with a submucosal leiomyoma, which could have bled. Here is endometrial cancer. This is endometrium, which is normal. This is abnormal. But the margin between the normal and the abnormal is not very clear at all here. Not very clear. But this needs to be biopsied, and this would typically be picked up on an endometrial biopsy. You don't need to do hysteroscopy for this. Endometrial stripe, I showed you this yesterday, a narrow endometrial stripe. You would expect the estrogen level to be very low. With estrogen level very low, what's the likelihood of endometrial carcinoma? With a thin endometrial stripe, very low, but it's not zero. So, if you see a wide stripe, it is concerning, but even with a narrow stripe, you've got to do endometrial biopsy in order to rule out endometrial carcinoma. This is the uterus. Here is the cervical canal. And can you see how thick the endometrium is here? Pretty thick. This could be hyperplasia and even cancer. I already showed you the saline sonogram. All right, staging. Cervical cancer is staged clinically. Vulvar cancer is staged surgically. Endometrial cancer is staged surgically. So we're going to have to do a hysterectomy and salpingo oophorectomy. Stage 1, stage 2, stage 3, stage 4. Stage 1 is limited to the uterus. It's the most common stage of diagnosis. Limited to endometrium, or less than half the myometrium is 1A. Invasion more than one half the myometrium is 1B. That's the most common stage. Then we have extension to the cervix, but not outside the uterus. Then we can have spread adjacent to the uterus, and then we can have stage 4, which is the bladder or rectum or distant metastasis. I don't know whether you need to remember all this, but I think I would remember stage 1, 1A, and 1B. That's the most common. So 1A, limited to the uterus, only the endometrium, or less than 50% of myometrial invasion. 1B is more than 50% myometrial invasion. Now, which do you think would be more likely to have metastasis? Stage 1A or 1B? Obviously, it's 1B. So that's where the staging is important. What if you find that the spread has gone through the uterine wall, through the serosa? That's going to be even higher. As usual, low stage, high survival. High stage, low survival. And the more aggressive you would be with the advanced stages. Okay, what do we see here? Here's the uterus. This is the leiomyoma. And here we have only the endometrium involved. So this would be clearly stage 1A. This patient probably does not require any radiation, doesn't require any chemotherapy, doesn't require any lymph node dissection. What do you see here? See, this has gone over halfway into the myometrium. Again, compare the likelihood of metastasis from this versus this. Obviously much higher over here. And it's invading into the myometrium, but has not gone all the way through. There's no way you will know this without doing a hysterectomy. All right, this is stage 3. If it has gone outside of the uterus and involves the ovary. And what we have here is endometrial carcinoma that has filled the uterine cavity, has come through the fallopian tube, and has gone on to the ovary. So this now would be called ovarian cancer metastatic from the endometrium. And although it doesn't show the other side here, this is typically bilateral. Ovarian cancer, which is metastatic from somewhere else, is typically on both sides. And this shows why we do a TAH, but also a salpingo-oophorectomy, a bilateral salpingo-oophorectomy, because you could have endometrial carcinoma, which is in the tubes and on the surface of the ovary. So we take very careful to remove the tubes and ovary and not spill anything into the peritoneal cavity. And here you can see the endometrial cancer has gone down to the cervix. It has gone laterally into the perimetrium, into the broad ligament. But first, it has to go through the myometrium. And here it goes down into the cervix. So this is stage 2 down here, and this would be stage 3. Management. Any cancer is going to have the potential of 3 kinds of therapy. This is on page 185 in the book. It could be surgical therapy, it could be radiation therapy, and it can be chemotherapy. For endometrial carcinoma, the mainstay of treatment is TAH and BSO, and maybe para-aortic lymphadenectomy. Once you're in there, you can check and see, is there any enlargement of the para-aortic lymph nodes? So what we've got is vulvar cancer spreads to the inguinal lymph nodes. Cervical cancer spreads to the pelvic nodes, which is in the broad ligament. And endometrial cancer spreads to the para-aortic nodes. And that would make sense just from the anatomy. This is on page 185. And you can see for stage 1, 2, 3, or 4, TAH, BSO on all of these patients. And then selectively using radiation and chemo, depending on what the extent of spread is, what the staging is. But every patient will have a TAH and BSO. Prevention. If the etiology, the pathophysiology of endometrial cancer is unopposed estrogen, then our prevention would move toward avoiding unopposed estrogen. So if the pathophysiology is unopposed estrogen, we need to bring some progesterone on. If it's a postmenopausal woman, anytime we give estrogen, and we're going to talk about that probably on Thursday, we always need to give progestin as well, because this will offset the stimulation of the estrogen. Now, what if you have a reproductive age woman with polycystic ovarian syndrome, chronic anovulation? She has only estrogen. She doesn't ovulate, so she doesn't have a corpus luteum to produce progesterone. She is at risk for endometrial hyperplasia. So for her, does she need the estrogen? No, only the progestin. Now, sometimes we'll go ahead and put them on the oral contraceptive pills just for convenience sake, but she doesn't need the estrogen. Okay, the lymph nodes. The vulvar cancer spreads to the inguinal nodes. The cervical cancer spreads to the pelvic nodes, which are in the broad ligament. And the endometrial cancer spreads to the para-aortic nodes. Now, where does ovarian cancer spread to? See, ovarian cancer does not spread primarily through the lymph nodes. It spreads intraperitoneally through the peritoneal fluid. So it is intraperitoneal spread. Okay, so remember, anytime you have estrogen without progesterone, you have an increased risk of endometrial hyperplasia. So you've got to give progestin, and that could be either to the postmenopausal woman who is on estrogen or the reproductive age woman who is not ovulating. And a common one that we use is MPA, medroxyprogesterone acetate, or Provera is the trade name, but they don't use the trade names on the exam. Okay, this is in your book on page 185. The natural history of the endometrium if there is unopposed estrogen. Initially, we get simple hyperplasia, no atypia. Likelihood of cancer developing from this is very low. Over time, with unopposed estrogen, it can become complex hyperplasia, no atypia. Over time, complex hyperplasia, no atypia can become complex hyperplasia with atypia. Now, this is a pre-malignant state. Complex hyperplasia with atypia in 30% of cases will progress on to endometrial carcinoma. The treatment for simple hyperplasia, no atypia, is progestin, MPA. You could use levonorgestrel as well. Complex hyperplasia, no atypia, again, medical treatment, progestin. Repeat the biopsy in 3 to 6 months, make sure it's gone away. Complex hyperplasia with atypia is pre-malignant. If possible, I would like to do a hysterectomy. This can be a vaginal hysterectomy. It doesn't need to be an abdominal hysterectomy. But if she's not a surgical candidate because of heart disease or lung disease or whatever, then you may try progestin, but it's not nearly as effective. But all endometrial carcinoma needs to have a TAH and BSL. That is without exception. And this is in your book. Okay, it's exactly the same. Okay, here is MPA, medroxyprogesterone acetate, trade name is Provera, celebrating a progestogen you have used for 35 years. Now this word progestogen means it is a synthetic progestin. And sometimes the word progestin and progestogen are used interchangeably. It's really the same thing. It's a synthetic progesterone. MPA, medroxyprogesterone acetate. Now, when you look at the relationship of long-term oral contraceptive use versus the risk of endometrial cancer, it's very interesting. This is looking at the relative risk of endometrial cancer on the x-axis. A risk of 1, which is right here, and is this vertical red line that I've drawn in. If you have a risk which is less than average, you will move over to this side, to the left. If you have an increased risk, you will move to this side here, and your number will be over 1. And you can see on almost all of these studies, with one exception, there is a reduction in the rate of endometrial cancer after 10 years or more of oral contraceptives. So this is a non-contraceptive benefit of steroid contraceptives. And what it does is it provides the progestin which stabilizes endometrium. And that's what then gives the prevention, oral contraceptives. So that's significant. And that, I think, is worth knowing for the exam. Now, here is looking at rates of endometrial cancer, age-related, United States and Japan. Why is there such a higher endometrial cancer in the United States than Japan? Is it because women aren't as obese? I'm not sure you could say that. What is, many times the cancer rates, which are different around the world, are because of lifestyle. And I think there is good evidence that tofu can make a difference in the endometrial cancer. And here is an article. Eating soy decrease the risk of endometrial cancer by 50% in women, especially who are over obese, 30 to 40%. So your diet can make a difference. 40% of cancers, according to the United Kingdom Cancer Research Unit, 40% are due to lifestyle, caused by avoidable lifestyle choices, such as smoking, drinking, and eating the wrong things. Are you listening to me? See, you guys think that you can live forever. You're young and healthy. You just wait. What do you think? Do you think you should be a vegetarian? Does diet make a difference? This is an interesting study. This is by Dan Buettner, who studied people who lived the longest around the world. And he found that these were areas which were easily demarcated. He labeled these the blue zones. These are areas where people lived the longest. Okay, they lived the longest. And the areas which he described were in Okinawa, Japan, in Sardinia, Italy, and what's this? Loma Linda, California. Ain't that interesting? Loma Linda, California. How could that be? Blue zones, regions of the world where people commonly live active lives past the age of 100 years. Loma Linda, Sardinia, and Okinawa, Japan. And what he looked at, what was the commonalities between these areas? Family being important, no smoking, a plant-based diet, constant moderate physical activity, social engagement, and legumes. Legumes are peas and beans and that kind of thing. Your lifestyle does make a difference. Interesting, 30,000 Seventh-day Adventists who largely live in the Loma Linda area have been studied for many years. And what they found was if you have a vegetarian diet, you can live an average of 2 years longer. Regular exercise, add 2 years. No smoking, add 2 years. Normal weight, whether it's Jenny Craig, whether it's Weight Watchers, whatever, Dr. Atkins, at 10 years. Eat nuts, be a little nutty. Your lifestyle does make a difference. Now, I'm on this study, and I do all this stuff, and I hope that I'm going to live a long time, but more than hoping that I live a long time, I hope my brain sticks around. The kind of nuts is the tree nuts. Peanuts are not true nuts. They are nuts which grow on trees as a result of the blossoms, which become a true nut. Okay. Anyway, eating nuts cuts coronary heart disease risk. Working long hours is harder on women than men because it makes them drink more likely smoke, drink coffee, eat unhealthy food. Ladies, are you listening? Vegetables linked to fewer breast cancers. Soy intake may reduce breast cancer risk. Well, enough. You guys think you can live forever, but you won't. You'll listen to me sometime. Okay, before we end this chapter, this is a good board question. What estrogen receptor modulator is associated with increased endometrial cancer and hyperplasia? And that is tamoxifen. Tamoxifen is a selective estrogen receptor modulator, SERM. SERMs are associated with estrogen agonist effects on some tissues, estrogen antagonist effect on the other tissues. Tamoxifen is an estrogen antagonist on the breast, but it is an estrogen agonist on the endometrium. So you need to watch for endometrial carcinoma. Endometrial cancer in women receiving tamoxifen. And there we are, June 4, 1967. Okay, thank you very much. Let's take our last break of the evening. See you in 10 minutes. Okay, so welcome back to the last hour for tonight, and we're going to go to chapter 5, disorders of the ovary and the oviducts. The first thing we want to talk about is physiologic ovarian enlargement. Here's our case, page 187. A 22-year-old woman comes for annual exam and requests oral contraceptive pills. On pelvic exam, she has a 6 centimeter mobile, smooth, soft left adnexal mass, which is palpable. An endovaginal pelvic ultrasound shows a 6 centimeter round, fluid-filled, simple ovarian cyst without septations or calcifications. She has no other significant personal or family history. So when we have a 22-year-old woman, what is the likelihood of her having ovarian cancer? Can a 22-year-old woman have ovarian cancer? Yes, she could. Could a prepubertal girl have ovarian cancer? Yes, she could, but it is certainly less likely. Now, what is the chance of a mobile, smooth, soft, round, fluid-filled, simple cyst being cancer? 0. So this is not cancer. What is it most likely? In a young woman in the reproductive years, it's most likely a functional cyst. When we look at a functional cyst, it should be a simple cyst. It should look like this. It is fluid-filled. It is round and smooth, no septations, no calcifications. It looks like a water balloon. This is a 2.8 by 3 centimeters in size. Now, this actually is about the size of a dominant follicle just prior to ovulation. So many women who are ovulatory normally will have at some point in their cycles a pelvic mass which is this size. It is not going to be palpable typically when it is this size. But when it gets bigger, and this one is 7.8 by 11.6 centimeters, but you can see it has the same characteristics. It is round and it is smooth. There is no calcifications. There is no septations. This is benign. This is in your book, page 188. Okay, a pelvic mass in the reproductive years, the most likely thing you should think of is a pregnancy. Get a beta HCG. If there's a beta HCG which is negative, you've ruled out pregnancy. The next thing is to get a sonogram. If the sonogram shows a simple cyst, fluid-filled, then it is most likely going to be a functional ovarian mass. So, pelvic mass, reproductive years, next step in management, beta HCG. Beta HCG is negative, next step is a sonogram, a vaginal sonogram. Now, this looks like a round fluid-filled cyst. I don't know why they took it out. I don't know why they have a oviduct here, but they did. But this looks very benign to me. All right. Pregnancy, the most common cause of pelvic mass in reproductive years. Next step in management, beta HCG. The most common complex mass is a benign cystic teratoma in a young woman. All right, the diagnosis, we already said, beta HCG, followed by a sonogram. If it is a simple cyst, if it is without calcifications, without septations, it's most likely functional and it can be managed expectantly. Observation, wait for 6 to 8 weeks. If it's still there, then you need to take it out laparoscopically. This is a physiologically enlarged ovary, a polycystic ovary. This is going to be bilateral. This is an ultrasound showing an enlarged ovary, and you can see the peripheral cysts which are around the edge here. Leave these alone. Don't do anything to these. Now, here you can see we have bilaterally enlarged ovaries. And this almost looks a little bit like tapioca. These are luteomas of pregnancy. When you have bilateral ovarian enlargement in pregnancy, it is almost always going to be a hormonally induced effect. Don't remove them, leave them alone, and as the hormones come down, they will go away. Here again, luteomas of pregnancy. They can be also androgen producing and can cause virilization. What is this here? What do we have here? This looks like omentum. So this is the uterus, this is the ovaries, this is the omentum. If you're going to operate on a woman in the reproductive, or during pregnancy, what would be the best trimester? The first, the second, or the third trimester? And it would be the second trimester. First trimester, you're concerned about pregnancy loss. Third trimester, you're concerned about preterm labor. So, but I wouldn't operate normally on a patient like this. These are large ovaries on either side of this uterus. Here you can see the clitoromegaly because of the high androgens which were there. Theca-lutein ovaries, usually stimulated by hormones. It could be FSH, follicle stimulating hormone. It could be HCG from a molar pregnancy. So molar pregnancy, multiple gestation, can have high levels of HCG. Natural history of these, you leave them alone, they'll go away on their own. They will regress. Will they turn into malignancy? Do you need to be concerned about cancer? No. Okay, what is the management then? Conservative management, observation. Look how huge these ovaries are. They can become absolutely huge. And if you have ovarian stimulation, like with artificial, some of these cysts can be pretty good size. All right, we're going to go through prepubertal adnexal mass. We're going to go through reproductive mass in the reproductive years, and then we're going to look at postmenopausal. Prepubertal pelvic mass. An 8-year-old girl is seen in the emergency department for sudden onset of severe lower abdominal pain. General surgery consult was obtained. Appendicitis is ruled out. Sonogram shows a 7-centimeter solid, irregular right adnexal mass. Pelvic exam confirms a 7-centimeter right adnexal mass. There's lower abdominal tenderness, but no rebound present. So we have an 8-year-old. The average age of puberty is going to be older than that. This is a prepubertal girl. If you're going to have a pelvic mass which is benign, would you rather have a solid or a cystic? Cystic. Would you rather have an irregular or smooth? Smooth. See, is it possible for a prepubertal girl to have an ovarian cancer? Yes, she can. Yes, she can, although it is rare. What's the likelihood? A solid adnexal mass is a functional mass. 0. 0. Okay, this is in your notes, and it is on page 190 on the bottom, but I'm going to put it in color. Surgical diagnosis is absolutely essential. You do not watch a prepubertal pelvic mass. It cannot be functional. Cyst, you can do it with minimally invasive surgery, a laparoscopic removal. If it is a complex or a solid mass, then you need to be concerned, could it be a cancer? And anytime you have concern for cancer, you need to do staging, laparotomy. A staging laparotomy. All right. If it's benign, simple cyst, laparoscopy, cystectomy, you just take out the cyst, then just regular follow-up. No problem. But if it is complex or solid, if it turns out to be malignant, now you've got a problem. Now, typically on a postmenopausal woman who has ovarian cancer, we're going to do a TAH, BSO, omentectomy, and tumor debulking. In a prepubertal, do we want to do radical surgery like that? What we find is that most of these prepubertal girls have germ cell tumors, and germ cell tumors are typically very responsive to chemotherapy. So we will take a calculated risk here. Instead of doing a hysterectomy and bilateral salpingo oophorectomy, we will do a unilateral salpingo oophorectomy, only on the side which is involved. Most of these will be stage 1, which is limited to the ovary. And then you can do surgical staging, looking to see if there's anything around. Most of the time, there is nothing else in the peritoneal cavity, and we can do chemotherapy. And what is amazing with these, 95% survival with chemotherapy. So, prepubertal pelvic mass, if it is complex or solid, laparotomy, unilateral salpingo oophorectomy, staging, and chemotherapy. Okay, now we look at, in the reproductive years, a premenopausal adnexal mass. If the patient has a negative beta HCG, if there is no pregnancy, then we want to look to see, is it complex? Is it solid? Is it cystic? Is it complex, partially solid, partially cystic, or is it solid? And the ultrasound, the sonogram, is going to tell us. The sono appearance is going to be important because the only functional cysts that we have are simple cysts that look like this. If it looks like this, if it looks like this, it cannot be a functional cyst. All right, let's look at the handout that I gave you. This is a busy one, but I think if we follow through it, it'll make sense. First is, if we have a pelvic mass in the reproductive years, the first thing you want to do is to get a qualitative beta HCG. Is it positive or negative? Because if it's negative, you do not have a pregnancy. But the most common cause of a pelvic mass is pregnancy. And then we want to get a pelvic sonogram. So we can have non-ovarian etiology, reproductive tract, urinary tract, and GI tract are the 3 organ systems in the pelvis. We must rule out pregnancy with a negative beta HCG. You could also have a hydrosalpinx, which is a fluid-filled simple cyst. Leiomyoma would be a solid mass. A tubal ovarian abscess would be complex, and that's from an old PID. Pelvic kidney diverticulosis would be less of a problem. But we start out with a beta HCG and pelvic sonogram. Now, if it is an ovarian etiology, and if it is functional, it will be a simple cyst. It will be either a follicular cyst, which would be in the first half of the cycle. It would be a lutein cyst in the second half of the cycle. Okay. So in the proliferative phase, it would be a follicular cyst, a corpus luteum cyst in the luteal phase. Now, if it is a neoplastic mass in a young woman, I mentioned this before, a dermoid cyst. This is my shorthand for benign. A dermoid cyst, a benign cystic teratoma, that is benign, but that's common in young reproductive years. Dysgerminoma is the most common solid cancer of the ovary in a young woman. You can also have an endometrioma, which is not a functional mass. It is not a neoplastic. And a para-ovarian cyst, which I'll show you a picture of. All right, so let's say we've ruled out pregnancy. It is a simple cyst. So it is not a dermoid. It is not dysgerminoma. It is not endometrioma. Okay, where do we go now? If it is complex or solid, it can never be functional because a functional is only a simple cyst. Now we need to do surgical excision. If it appears benign, we can do a laparoscopy. If it appears malignant, we need to do laparotomy because we need to do staging. So complex or solid, never functional, you got to take it out. If it looks simple, like a fluid-filled balloon, then it could possibly be functional. The question is, are we going to leave it or are we going to take it out? Is she on steroid contraception? Is she on oral contraceptive pills? If she is on steroid contraception, estrogen and progestin, FSH will be suppressed. LH will be suppressed. It cannot be a follicular cyst. It cannot be a corpus luteum cyst because she's not going to ovulate. In that case, we need to do surgery. All right. If she's not on steroid contraception and it is a simple cyst, the next question is, how big is it? And is it mobile? See, if it is over 10 centimeters in size and if it is mobile, you've got a high risk of torsion. What will be the symptoms if you have torsion? You're going to have acute onset of unilateral pain in the presence of a pelvic mass, right? That's torsion. And so if it's large and mobile, you may need to be aggressive and not be conservative and do surgery and take it out. But if it is a simple cyst, she's not on steroid contraception, it's not over 10 centimeters in size, then you could just wait. Repeat the sonogram in 6 to 8 weeks. If the mass is still there in spite of watching, if it persists, then you're going to have to take it out. If it is resolved, if it has gone away, we're done. And so we make an assumption that it must have been a functional mass. So that should take you through pretty well any premenopausal pelvic mass. The most common is going to be a simple cyst, a corpus luteum cyst, or a follicular cyst. And the management for that is just wait. Over time, it's going to get smaller and it's going to regress. You don't need to put the patient on oral contraceptive pills. Oral contraceptive pills will not reduce a mass which is already there. What oral contraceptive pills will do, it will suppress FSH and LH, and she will not have any recurrence. But it doesn't do anything to those which are already there. Okay, let's look at a complex mass. A 28-year-old woman is in the emergency department with lower abdominal discomfort for 5 days. Is this acute onset? Well, not really. 5 days, it's not chronic either. See, it makes a difference if you have acute onset or if it's chronic. She has not used any oral contraceptive pills. A year ago, pelvic exam and pap smear were negative. Pelvic exam today shows a 7-centimeter, mobile, painless, right adnexal mass. Vaginal sonogram shows a 7-centimeter, mobile, irregular, complex mass with prominent calcifications. So what do you think could be a complex, irregular mass with calcifications? That sounds like a benign cystic teratoma. That sounds like a dermoid cyst. And here we have the dermoid. You can see it is well encapsulated. Here it has hair, fat, and it can even have teeth in it. Histologically, you can see cartilage, fat, and thyroid. If it's mostly thyroid, it can be called struma ovarian. How do you know if it's a dermoid cyst? You put the patient in a cold room and you listen for the teeth to chatter. Look at the hair here. Amazing, amazing hair. Benign cystic teratoma. Now here's one that has almost looks like a jaw in here. Look at all the calcifications in this dermoid cyst. Now this one is being taken out and it looks healthy, well perfused. So does this one here. Now this is a pretty big one. Why would you take this one out? How long had it been there? This is huge. This is a hydatid cystum morgagni, a para-ovarian cyst. It's not neoplastic, it's really an embryological remnant. But can you see how long the pedicle is here? Can you see how easy this would be to tors, to cut off the blood supply? This is a luteoma pregnancy. We didn't know this until histology showed us that. Now, this is a benign mass. Could be a dysgerminoma. Now, this is a pretty big abdomen. And it looks like she's pregnant, but she really isn't pregnant. It is really a ovarian mass. Now, I want to show you the biggest one that I was involved in taking out. This is a abdomen which has a huge mass in it. And here we are opening up the abdomen. We went from the symphysis to the xiphoid in order to get this out. You can see we're lifting up this huge mass. We're clamping the ovarian pedicle. And this is what it looked like. It was probably about 40 pounds in size. It turned out to be a serous cystadenoma. It was benign, but it sure was big. And this woman also had a mucinous cystadenoma, and it turned out to be 128 pounds, which is as much as she weighed. Huge. So that's going to be a complex mass. Let's look at a painful adnexal mass. 31-year-old woman is taken to the emergency department complaining of sudden lower abdominal pain for 3 hours. She was at work when she developed lower abdominal discomfort and pain which got progressively worse. Notice the sudden onset. On exam, the abdomen is tender without rebound. Without rebound means you don't have peritoneal involvement. But there is suggestion of an adnexal mass in the cul-de-sac. Ultrasound shows an 8-centimeter left adnexal mass with suggestion of torsion of the ovary. How would you know that there could be torsion of the mass? And you can use color Doppler to look for the blood supply. Sudden onset, severe low abdominal pain, cystectomy, if it's like, for instance, a benign cystic teratoma. Take out the abnormal, leave the normal tissue. And if revitalization occurs, you can preserve the ovary. But if the ovary is necrotic, you may have to do a unilateral self-injectomy and take it out. Here is a mass that you can see is ischemic. This one cannot be preserved, as is this one here. So you don't want to wait too long if you suspect that you have ovarian torsion. Now, you could have torsion and then reversal, intermittent torsion back and forth, and that can be intermittent pain. So abrupt onset of unilateral pelvic pain, negative beta HCG in the presence of an adnexal mass, you better think of ovarian torsion. The last topic here is a postmenopausal adnexal mass. And what is your concern with a postmenopausal adnexal mass? You're concerned about, let's see what you got. And it is, okay, what kind of neoplasia? What kind of CA? Ovarian cancer, Suzanne. Ovarian cancer is a big concern with a postmenopausal adnexal mass. And here is the slide I've showed you before. And here you can see the ovary is number 2 in gynecologic cancers. Second, and it is most commonly diagnosed in stage 3 because there are no good early warning symptoms. Average age is 69. So this is women who are in the later years of life. Okay, a 70-year-old woman, 70, comes for annual exam with lower abdominal discomfort. However, there is no weight loss or abdominal distension. On pelvic exam, you find a non-tender, 6-centimeter, solid, irregular, fixed left adnexal mass. What is the likelihood of a 70-year-old woman with a non-tender, solid, irregular, fixed mass being a functional mass? a functional cyst? And the answer is 0. There is no adnexal masses which are solid, irregular, fixed, which are functional, and certainly in a postmenopausal woman. This is really concerning for ovarian cancer. So let's look at our handout for ovarian cancer. We'll start out over here. What are the organ systems in the pelvis? There is a reproductive tract, there's a GI tract, there's a urinary tract. So whenever you have a mass, you need to think of hydrosalpinx, cervical cancer, endometrial cancer, do a pelvic exam, speculum exam, pap smear. The colorectal cancer is also a possibility. Diverticulosis, colorectal cancer, Crohn's disease. The urinary tract, in terms of pelvic, kidney, bladder cancer, would be less concerning. But certainly the GI tract, you need to think of. All right, let's say we've ruled out reproductive tract other than ovary. Let's say we have ruled out GI tract. We've ruled out a tissue biopsy. That's always true for any diagnosis of cancer. And most of these patients would require a staging laparotomy. Mostly we will see with epithelial ovarian cancer intraperitoneal spread. The most common ovarian cancer is serous. That is epithelial cancer, and it is the most common epithelial cancer. If there are any symptoms, they tend to be GI, dyspepsia, distress of the abdomen, difficulty in swallowing. Okay, before we operate, which we need to do, we need to get tumor markers. They are not for diagnosis. They're only for following to see if the tumor marker level comes down, if it is being cured, and if it comes back, if there's a recurrence. And you should know this for the exam. The most common ovarian cancers are epithelial. 80% are epithelial tumors. The tumor markers are CEA for metastatic disease and CA125 for serous tumors. This is the most common one. The germ cell tumors, they're 15% of tumors. You can see they're much less than the epithelial. The tumor markers HCG, which is a marker for choriocarcinoma, for embryonal cancer, and LDH for dysgerminoma. The least common is gonadal stromal, 5% of tumors. They can be endocrinologically active. Granulosa cell tumor can produce estrogen. A Sertoli Leidig cell can produce testosterone. These you should know for the exam. All right, we've got our tumor markers. Now where do we go? Surgical staging. When you open the peritoneal cavity, first thing you do is to put in some saline, 1,000 milliliters of saline, aspirate it up, and get peritoneal washings. Could you have microscopic spread? Because you could possibly get microscopic, but no gross spread. Then we do a total abdominal hysterectomy, bilateral salpingo-oophorectomy, an infracolic omentectomy. We're going to take out as much of the tumor mass as we possibly can. We call this cytoreductive debulking. Cyto, cells, reducing the number of cells by taking as much of the bulk of the tumor out. You'd like to leave no more than 1 centimeter masses. Therapy. What is a chemotherapy? Here we've got the two agents, which you should know. Carboplatinum is one, and Taxol. And beyond that, I don't think you need to know. Radiation therapy is not usually used with ovarian cancer because you're going to have to give whole abdomen radiation. The only radiation which would be used would be in a fluid medium, intraperitoneal radiation fluid, which will then only give enough radiation to get microscopic spread. But we don't give full beam radiation, external beam radiation for ovarian cancer. Okay. screening tests. Don't write these down. These are research tests only. Matrix metalloproteineases, lysophosphatidic acid. Here's one, I don't know how you even pronounce this. But wouldn't it be nice if there was a tumor screening test, like, for instance, with PSA for prostate? Of course, that has a lot of questions raised with it. But there really is no good early diagnostic screening test. This is a test which has been looked at, human epididymis protein 4, HE4, which is secreted by serous and endometrioid ovarian cancer. It is not for clinical use yet. Now, you might say, why don't we do ultrasound, pelvic ultrasound, on all women, postmenopausal women, to see if we can pick up ovarian cancer? Well, the problem is this. Cervical cancer, by doing pap smears, it costs $17,000 to prevent one death. Prostate cancer, $20,000 to prevent one death from, and we use PSA screening. Even mammography can protect. But in order to do ovarian cancer, you'd have to pay $400,000 to do all of the surgeries necessary to save one ovarian cancer life. And the reason for this is, of 100 postmenopausal women who have adnexal masses that are picked up by routine ultrasound, how many of that 100 do you think are going to be ovarian cancer? Let me give you multiple choice. 90%, 75%, 25%, 15%, 3%. It's only 3%. So can you justify operating on 97% of women unnecessarily? And the answer is no. So routine screening with ultrasound is not justified. Okay, epidemiologically, what do we know about ovarian cancer? The mean age is 69. We already talked about that. 1% of women will die of ovarian cancer. The most common gynecologic cancer that causes death is ovarian cancer. Now, risk factors. BRCA gene. That has an increased risk of cancer of the breast and cancer of the ovary. Sometimes that's linked to a positive family history. So that's one risk factor we should be aware of. Another one is the more lifetime ovulations a woman has, the more times the ovarian capsule has been broken by ovulation, the more healing that needs to take place, the more epithelial cancer. So if the number of lifetime ovulations increases a risk, how about if we decrease the number of lifetime ovulations? And how can you do that? Oral contraceptive pills will do that. Chronic anovulation, polycystic ovarian syndrome patients don't ovulate very often, and they have a lower rate of epithelial cancer. What is really interesting is tubal sterilization can decrease ovarian cancer, and I want to look at that in just a moment. Breastfeeding, it will decrease the number of ovulations. Short reproductive life will decrease the number of ovulations. This is Mary Claire King. This is a PhD professor of genetics in Seattle University of Washington, who in 1990 discovered the BRCA gene. And she was studying a woman by the name of Annie Parker, whose mother and sister were diagnosed with breast cancer. This is a movie made decoding Annie Parker. Helen Hunt was playing the role of Mary Claire King. This BRCA gene, Angelina Jolie had a double mastectomy because she was concerned about breast cancer, even though at this point she didn't have it. She had a double mastectomy. And here's the reason. If you are BRCA positive, your risk of breast cancer by age 50 is increased by 50%. By age 70, the risk of breast cancer is up 87%. The risk of a second breast cancer is up 64%, and ovarian cancer is up to 44%. So we've got significant issues in terms of breast and ovarian cancer with the BRCA gene. And it isn't entirely clear what do you do with these women At this point, certainly once they finish their reproductive life, take out the ovaries. And as Angelina Jolie had, was a subcutaneous mastectomy. So these are tough situations which many people are having to deal with. I mentioned we do a TAH and bilateral subpinguoophorectomy, and also to take out the omentum. This is the omentum. The omentum is the fatty apron, and what happens is a lot of the tumor will go to the omentum. So if you want to debulk the tumor, take out as much of the tumor, you need to take out the omentum. And you can see the intraperitoneal spread for ovarian cancer. And look at the spread here. It's just like a solid sheet. Sometimes you have to do bowel resection. Sometimes you have to do ileoconduit. So the gynecologic oncologists who work on these cases, they have long, long surgeries, sometimes 10, 12 hours. Okay, what are the symptoms of ovarian cancer? The symptoms of ovarian cancer are very subtle. Ovarian cancer whispers. So listen carefully. Unusual bloating, fullness, pressure, abdominal or back pain, lack of energy. Now, those are so nondescript. Unless you think of it, you may miss it. You see, cervical cancer screams at you, abnormal pap smear. Endometrial cancer screams at you with bleeding. But ovarian cancer, not so obvious. So this is the American Cancer Society. Early signs are identified. Bloating, frequent urination, eating changes, abdominal pain. Patients who had symptoms prior to diagnosis, 3 months before, 75% of the patients had GI symptoms. 6 months before, 50% had pain. So those subtle, perhaps non-specific symptoms may be suggestion of ovarian cancer. The ovarian cancer starts in the ovaries, here and here. What organs are beside the ovaries? There's none. The ovaries are just sitting out there. If there are tumor cells which drop off, they're going to drop down into peritoneal fluid, and what will happen to them? They're going to flow all through the peritoneal cavity, around the bowel, around the kidneys, behind the diaphragm, behind the spleen. So you have diffuse peritoneal spread, stage 3. Now, this makes it clear why you can't radiate with external beam radiation, because you're going to kill off the liver, you're going to kill off the kidneys, you're going to kill off the bowel. So largely, ovarian cancer treatment is surgery and chemo. This is looking at the risk of ovarian epithelial cancer as a function of long-term oral contraceptives. And this is 1 year, 1 to 4 years, 5 to 8 years, 10 to 14 years. You can see after 10 years, it's almost a 50% reduction in ovarian cancer, very similar to the reduction in endometrial cancer with long-term oral contraceptive pills. So that would be a good board question. This looks at long-term pill, contraceptive pill. This is 28 women with the pill, will have cancer without the pill, and these are women who took 10 years of oral contraceptives. So we're looking at a significant reduction with oral contraceptive pills. This is on page 194 in your book, and the epithelial cancers that we look at are mucinous, serous, endometrioid, clear cell, and Brenner's. The germ cell are teratomas, dysderminoma, endodermal sinus, immature teratoma, choriocarcinoma, and monodermal, and the stromal, which are 15% here and 5% here. I don't know of any tissue in the body that has as many types histologically as does ovarian. Now, this is interesting. Many believe that serous carcinoma of the ovary arises from the fallopian tube. Yes, it arises and it goes to the ovary. So what they're suggesting here is routine removal of the oviducts to reduce the risk of ovarian cancer after the reproductive years are finished. Routine bilateral salpingectomy with hysterectomy gains acceptance. Notice it's not oophorectomy. It's not taking out the ovaries. You leave the ovaries in, but you take out the tubes. Very interesting. Okay, we've already talked about the tumor types and the percentages. Epithelial, 80% older women. Germ cell, 15% younger women. And gonadal stromal, 5%. And that can be in any age group. And here it is in your notes. Tumor markers, we already talked about that. CA125, CEA, LDH, HCG, alpha-fetoprotein, estrogen, testosterone. These are the epithelial, these are the germ cell, and these are the gonadal stroma. Staging. Stage 1, Stage 2, Stage 3, Stage 4. What's the most common one? Stage 3. I don't think I would remember all this stuff, except that Stage 1A is one ovary, intact capsule, no positive cytology in the peritoneal cavity. 1B, both ovaries, but the capsule is intact. It hasn't gone anywhere else. Stage 1C is when the capsule is ruptured and you have positive washings of the peritoneal cavity. 65% is diagnosed in stage 3. That's not good. The average survival, 5-year survival, is only 15% with stage 3. So we're going to be very aggressive in our management. This is looking at optimal debulking, taking out the tumor masses, survival 52 months. Non-optimal debulking, it's only half of that. This is a woman who lived over 20 years after diagnosis of stage 3 ovarian cancer. This woman is still alive. She is 11 years post-diagnosis of stage 3. So be aggressive. This is an interesting case. This is actually the mother of President Obama, who is right here. Stanley Ann Dunham. And what's interesting here, she was working in Indonesia. One night at a friend's house, she experienced stomach pain, GI symptoms. She went to a local physician of indigestion. So what was really going on? When she came back to the United States, to Sloan Kettering, it was found that she had bilateral ovarian cancer, metastatic from the ovaries. And she died, age 52. This is Pierce Brosnan, who was 007 in the movies. His wife, his mother, his wife died at age 43 from ovarian cancer, and here's his daughter, died also at age 41. And this is Dr. Martin Luther King's wife. She died of ovarian cancer, stage 3. So even important people can get it. All right. And I think that should be enough for tonight. We will pick up tomorrow with chapter 6, which is gestational trophoblastic neoplasia. And it is my pleasure. Thank you very much.